Thank you for telling me. Okay, I want to finish some concepts that are in relation with um, the component of OB and neonatology for Nclex. And for example, there are questions about the breast engorgement, which is a normal condition, a physiological condition that occurs immediately after birth, soon after birth, generally 24, 48, 72 hours after birth. The breasts are overstimulated by the prolactin and the drop of the level of estrogens, and for that reason start producing milk. And the milk are going to make the breast uncomfortable because they are, swollen, they are lumpy, and they are, mildly painful, very hot. And this condition is called engorgement. You must know that there are two outcomes possible to this engorgement. One is that the woman doesn't want to breastfeed, which is very common in our culture. In that case, the recommendation is to use cold, and to avoid touching the nipples because cold blocks this process, decreases the production of milk, and avoidance of stimulation of the nipples will, stop the stimulation of the secretion of prolactin, and for that reason, and oxytocin, and for that reason, the engorgement will improve. Doctors can decide. This is a decision between the doctor and the patient, the use of estrogens, okay, to block the production of milk. It is important to pay attention to this detail because you need to know that if a woman wants to breastfeed, cannot take estrogens because the estrogen will, And remember that the contraceptive, the pill, has estrogens. So estrogens will stop the production of milk. There are contraceptives that don't have estrogens. They are contraceptive of only progestin that the progestin doesn't, okay, inhibit the production of milk. The other outcome is that the woman, yes, wants to breastfeed. In that case, we recommend warmth. We recommend local heat for the engorgement and the most effective of all the interventions. Take the baby and put the baby to suck in the breast, and this is going to immediately improve the engorgement. It's expected that during breastfeeding, when the baby stimulates the nipple, oxytocin will be produced by the pituitary gland of the woman, and the oxytocin will produce a strong contraction of the uterine musculature, and this is going to produce cramping. So the cramping is painful. Is a expected phenomenon during breastfeeding, but it does not mean that you are not going to provide analgesia. And one recommendation, doctors prescribe analgesics, painkillers, for this pain. And the recommendation is to give this painkiller a while, half an hour before the breastfeeding to, decrease the discomfort that occurs in the recent postpartum during the breastfeeding. So how can be tested that a woman has pain when breastfeeding? What is the most important intervention? Explain that it is an expected pain as consequence of the release of oxytocin by the stimulation of the nipples, or B, give the painkiller prescribed by the doctor. Of course, the woman is not interested in the moment that is having the pain of your a scientific explanation. What the woman would be interested is in a relief of the pain. So that your common sense, your logic says that the most important is to administer the medication. When the patient is not in pain, you can give the teaching, the explanation, but you are not supposed to give teaching to a person that is experiencing pain. The priority at that moment is to relieve the pain, and then when the patient has no pain, comes the teaching. It's an example of question in English in relation with this to anticipate you. Maybe you could choose teaching the patient that it is an expected pain, that is a physiological pain, but the woman is not interested in that. The woman is interested in the relief of the pain, which makes sense. Put you in the position of the woman. Very good. Other aspect that is interesting in the postpartum is that the vital signs of women during the postpartum are crazy. The temperature elevate, no beyond 100 degrees, not beyond 100 degrees, but it increases normally as part of the process of the hormonal changes, and it can be confusing. It can be could be confusing, and the person, the nurse could be thinking in an infection. The other phenomenon that occurs is in the blood during labor, and in the first day or days after birth is a physiological, a normal, expected leukocytosis that can be as high as 20,000, okay, in the 20,000 levels. Again, this is confusing because then being a physiological phenomenon could confuse the nurse thinking in infection. So need to be taking in consideration that these two parameters are difficult to interpret during the postpartum. It's not usual that in the immediate postpartum, when these two conditions occur, that the woman get infected. If a infection occurs as a complication of the of the partum, I mean, an endometritis occurs or abscess, etc., tends to occur after this period in which this elevation of the temperature and the white blood cells occurs physiologically in the postpartum. Another phenomenon can be seen in the postpartum is bradycardia. Meanwhile, in the pregnancy, along the pregnancy and during labor, the expected is tachycardia. Uh, in the postpartum, then can appear bradycardia and could be as low as 50, and it's physiological. It's a sign of bradycardia, but also orthostatic hypotension. The orthostatic hypotension is a common phenomenon in the postpartum. And when the woman stands up, going to the bathroom, because there are also diuresis after the postpartum, there is risk of fainting and falling and risk for injury. So it's a risky, it's a safe issue that we need to have, a safety issue that we have in mind. You know that the uterus normally should shrink in the postpartum. The uterus that was in the sternum was in the epigastrium. After the birth, the exit of the fetus and the placenta should be around the umbilicus, maximum 2 centimeters to 2 finger breadth above the umbilicus. This is the max, the highest that the uterus can be normally, and should be in the midline. So if this is the abdomen, you don't expect the uterus. I will forget to use my. I think that I'm in Zoom when I connect with you. I'm not in Zoom, Beijing. I'm in Teams. Okay, so if this is the uterus, you expect pardon, if this is the abdomen, you expect the uterus to be in the midline, okay, in the midline, okay, not deviated to the right or deviated to the left. If you find a uterus deviated of the midline, it's probably because the urinary bladder is distended. And when the urinary bladder that is in front of the uterus distends, pushes the uterus laterally. And it is an issue because this distension of the urinary bladder prevents the muscle of the uterus to contract efficiently. And for that reason, the uterus is buggy, and as a consequence, the woman can start bleeding. And it is important, very important, to rule out urinary distension in patients that have lateralization of the uterus and are bleeding, and the uterus is not well contracted. If they ask you what you do first if the woman is bleeding with a buggy or soft uterus, deviated from the midline and verified that the bladder is distended, the first is not massaging the uterus. You can become tired of massaging the uterus, and the uterus will not contract, because meanwhile the urinary bladder is distended, then the uterus will not contract. So first you empty the bladder, you make the patient pee, and then is when you do the massage to promote the contraction of the uterus. Um, um, this is important. The uterus should be firm, should be hard and tender if you touch it. If you touch the uterus in the postpartum and it's soft and it's non-tender, it's because it's not well contracted, and it's a concern. Uh, you know that doctors prescribe uterostimulant medication like the oxytocin, like methylergonobin, like the prostaglandins, okay, uh, to stimulate the contraction of the uterus, combined with analgesic for the after pains, for this pain that I described occurs there. So all those can be details that can be tested. Those are nursing business. Those are nursing business that you need to know. In relation with the lochia, you need to know that the normal is to have red blood, blood coming out for the first 2 or 3 days, 2 or 3 days. After that time is not expected. So a question could be, which of the following findings in the woman 7 days after birth that you visit at home in the follow-up should need follow-up? And then there are different symptoms that are expected, that are benign, and there is one. The woman is still 7 days later have, lochia rubra, so blood coming out. So obviously there is a problem that, is impairing the uterus involution and continuous bleeding. Later becomes, serosa and becomes alba. This is an issue. Another important aspect of the lochia should never be stinky. The smell is natural. It's a smell of blood, the body fluids, but never is a pungent, a strong or uh, uh, um, a stinky smell. So infections produces a very smelly, okay, lochia. The perineum frequently have swelling and sometimes has an episiotomy, and local ice in the first 24 hours is the adequate, because this will produce vasoconstriction and decrease of the swelling. But after the first 24 hours, as occurs in the orthopedic injuries, is convenient heat. And the best, because the heat is soothing and the heat promotes the circulation and the elimination of dead cells, etc. And it's going to improve the symptoms, the discomfort. And the heat, the best way of giving heat locally is the sit bath, okay? That is very simple. It's to be sitting in a container with warm water. That's it. Doesn't need to have any kind of substance water. It's just the warmth. Is cleaning, is the breathing, and is soothing of the discomfort. Sometimes there are hematomas that need to be reported, especially vaginal hematoma that is seen as a lump, a purple lump in protruding in the introitus of the vagina. Those are hematomas that can occur in the walls of the vagina because the trauma of the vaginal birth, especially when forceps are used. Be always aware of questions related with complications of the postpartum period. The most important of all and the most frequently tested is bleeding. You need to understand this is not going to be tested. You need to understand that inside the uterus, you will have a hole inside the uterus, okay? And in this hole is where the placenta was. This hole has blood vessels, huge blood vessels, arteries and veins that are very, very, dilated. And after the placenta detaches, it comes out, those blood vessels are left open and are going to bleed. No, are going to bleed. but the uterus is going to contract. This uterus is going to contract. The contraction of the uterus, strangle, occlude, okay, collapse these open blood vessels because the force of the contraction of the muscle closes those blood vessels. And this is what prevents the bleeding. So any failure of the uterus contracting after birth is what produces this bleeding. Very rarely, less frequent, okay, the bleeding comes from wounds or lacerations that can occur in the cervix or can occur in the wall of the vagina, but is a very less severe bleeding and is a bleeding that is not associated with the relaxed or baggy uterus. So the concern is this uterus that is not well contracted, is baggy, is soft, and is leaving those blood vessels open because the magnitude that this bleeding is catastrophic and is one of the main causes of postpartum mortality, of maternal mortality. So it is a super important issue. We're going to talk a little more about in the next slide. But don't forget that after birth can appear preeclampsia. That is the rationale of continuing the administration of magnesium sulfate after birth in clients with severe preeclampsia. By the way, it's an Nclex question. Why they continue giving magnesium sulfate after the birth for a while, uh, if we know that birth is the beginning of the cure of the resolution of the preeclampsia, because even after birth, the patient can have seizures. The preeclampsia can evolve to eclampsia, can have post seizures and eclampsia after birth. And the other important complication that need to be in your mind for test purposes is that deep vein thrombosis and pulmonary embolism are more frequent in postpartum, in the postpartum, than in any other moment of the women's life. And it's something they need to have in mind. The infections are, as I said, later. The endometritis is later. And generally, the endometritis or infection of the interior of the uterus will present with fever, signs of infections, and fetid, foul smelling lochia. And the woman will have history of premature rupture of membrane or prolonged rupture of membrane. When a woman who is in labor, breaks the membranes, those membranes that seal the interior of the uterus, it's expected that the woman would have the baby in the upcoming or the following 18 hours, maximum 18 hours. So if the woman has been with the membranes broken uh, for more than 18 hours and the baby has not yet uh, uh, born, so you need to consider the possibility there is a woman that has increased risk of posterior infection of the inside of the uterus because prolonged rupture of membrane. You don't need to know too much detail about that, but need to have the concept in your mind that the membranes are like a barrier uh, that prevents any bacteria, the normal flora of the vagina or the skin around the vagina to enter inside this sterile cavity that is the uterus. The uterus is sterile, the vagina has flora. What separates one from the other? The membranes. When the membranes are broken, there is some contamination of the interior of the uterus. The immune system of the woman is enough uh, to keep control of this contamination. But if this rupture is prolonged, then there is too much contamination that can overcome the capacity of defenses of the woman. Another important concept in relation with this premature rupture of membrane is that introducing the fingers in the vagina will sweep, will dislodge, will transfer, translocate the flora that is in the around the anus, which is near the vagina, and in the perineal skin, which is around the introitus of the vagina, toward the uterus. And you don't want to move, to displace this normal flora in the skin, in the intact skin, to the interior of the vagina where there is a wound inside the uterus. That is the endometrium and the space where the placenta was. So makes sense that vaginal examination is contraindicated, is avoided as much as possible after the membranes are broken, when this separation between the vagina and the interior of the uterus disappears. And should be, if it are needed, are done by the provider, by the physician, with sterile gloves and preferably with a speculum, to avoid introducing the fingers and on purpose. Because if you treat the fingers on purpose, you are moving the bacteria of the skin outside the vagina to the interior of the uterus. This is a question in the Nclex. What is the priority for a nurse in a woman with premature rupture or prolonged rupture of membranes? Is the right answer is avoiding vaginal examination, unnecessary vaginal examination. Why? For this explanation. Okay. Of course, you are going to have 3D structures that are very attractive, like giving antibiotics or etc., etc. But the priority is the prevention of the infection, and it is prevented with the avoidance of this manipulation. Remember that there is another contraindication for vaginal examination, which is the placenta previa. The placenta previa. Remember that. Okay. So this is the basic information that a entry-level nurse should have about OB and postpartum. Okay. In relation to the postpartum bleeding, they can ask you which woman that just had a baby, of many women that had a baby and you are under your care, which one has more risk of postpartum bleeding? Select that apply. And it is a common question. There are two, so what happens when the woman bleeds after birth? The uterus doesn't contract. So there are specific causes for this uterus not contracting. We already studied a distended urinary bladder, which is very easy to solve. If you detect and distend the urinary bladder, you know that the uterus won't be able to contract properly, and the solution is to empty the urinary bladder. But there are other two situations that, if you, instead of memorizing, makes logical analysis. If this uterus has been along all the pregnancy over distended, I mean, what was inside the uterus was too big. What could be the situation? Well, could be a big baby, so a macrosomic baby. Could be there are two babies or three babies or four babies, so multiple gestation. Okay. Or could be because there is too much liquid, some condition, some just malformation of the fetus can produce too much liquid, too much amniotic liquid inside, producing a very big uterus. Okay, it's called hydramnios. Okay, so this over distension could be a cause of that the uterus, after being emptied, after being evacuated, cannot contract properly. Makes sense. Makes sense. It's as being overstretched, then it's difficult to shrink again. So try to think in all those conditions that can produce an overdistension of the uterus. Another cause that could prevent this uterus from contracting are certain medication drugs that are used either during vaginal birth or during C-section that inhibit the contraction of the uterus. We already mentioned that magnesium sulfate is a tocolytic, is an uterus inhibitor that must be used if the woman is in labor or is going to C-section and also has a severe preeclampsia. So the recent administration of magnesium sulfate is an example of medication. Also anesthetics, muscle relaxants that are used during the C-section, cesarean section, And even the prolonged use of oxytocin for many, many hours can produce like a fatigue in the uterus. It's like, if you are working out, there is a moment that you are so tired that you cannot move your arms, you cannot move your legs. Makes sense? It's the same. So it is another condition. Uh, Sometimes, this is not frequent nowadays, you have women that have been history of many babies. So it's a woman that has 8 babies, 8 pregnancies. Those all uterus, all and overused uterus can age sooner, and for that reason the muscle deteriorates because they overuse many pregnancies, and for that reason many past pregnancy. Okay, and it also could be a cause of that the uterus is not able to contract properly during the postpartum, and the infections inside the uterus, okay, also inhibit the contraction, and it could be a reason. So over distended uterus, like macrosomia, multigestation, hydrangeas, grand multiparity, those women that have many babies, drugs like magnesium sulfate, infection, okay? The general anesthesia as medication. So the C-section has more risk of postpartum bleeding than a normal vaginal birth. The abroxio placenta and placenta previa can produce, hemorrhages, okay? Hemorrhages, okay? So those could be a question of cellular apply, which makes sense. Um, what we do if the uterus is soft, we massage the uterus. We massage the uterus, the front of the uterus, with these 2 fingers, one finger in the pubis to prevent the eversion or turning inside out the uterus, and with the other hand we make a massage. But if there is bladder distension, before do this, we need to empty the bladder. Yeah, maybe. And the use of uterus stimulant to make the uterus contract, like oxytocin, like methylergonobin, and the prostaglandin, like carboprost, uh, that that we mentioned that produce this stuff. By the way, it is accepted in Nclex question, in nursing question, that we should suspect that a woman is bleeding, because there is a normal bleeding in the postpartum, but you need to suspect there is an abnormal bleeding when the woman saturate. The word saturate is important because it's like soak a perineal pad in less than 1 hour. Yeah, if the woman saturates the pad in more than 1 hour, it's okay. But if saturation occurs in less than 1 hour, it's one of the most commonly description or scenarios to make you think that the woman is bleeding. Another question that is very common in Nclex, that there is a normal postpartum bleeding that confuse a lot nurses, on non-experienced nurses and non-experienced patients. That the anatomically, when a woman is recumbent, so is on bed, okay, is on bed. A postpartum woman is on bed, The vagina has a cul-de-sac, is like a cavity here in this part, being this the vagina. And here is the uterus, and the uterus just had a baby, is empty, but is normally producing a normal amount of blood. But in this position, the blood pools, accumulates here in the cul-de-sac that has the woman in the vagina. When this woman stands up, when this woman, okay, changes from this position to the standing position, in the moment of standing, the woman will notice that there is a flow, there is a gush of blood coming out. Very impressive. Okay, even staining the floor. Uh, is the blood accumulated here that when the clients stand up, this blood doesn't coagulate. When the woman stands up, is coming out. How I know that it is physiological is the pulling of the blood, the lochia rubra, along the hours the patient was sleeping or resting on bed. Very simple. We move the woman back to the bed, and I assess the uterus through the abdomen. If I notice that the uterus is well contracted, is firm, well contracted, and tender to the palpation, and the woman is stable, the vital cells are stable, you say, oh no, this I can assure you that this gush that came out and stopped is not coming out anymore. It only came out, very impressive, but stopped. Your uterus is well contracted, your vital signs are stable. This is the blood that is pulling in the cul-de-sac or the vagina. This question is very common in English. Okay, so uh, probably the ladies know about this, because even during menstruation, this phenomenon can occur. But maybe the gentlemen that are listening don't know about this. It is a normal bleeding. Okay. Um. So how you answer this question? A postpartum woman, after 6 hours of vaginal delivery, requests the help of the nurse to go to the bathroom. When assisting the client to getting up, the nurse observed a gush of dark blood coming from the client's vagina. The nurse palpates a firm uterus at the level of the navel. Navel, you know what it is. Some of my Hispanic students have had problem identifying what is the navel, okay, the umbilicus. Which of the following remember that you need to master vocabulary to be able to deal with the Nclex. Which of the following interventions should the nurse do next? So what you do first, immediately report the finding to the provider, initiate IV isotonic solution and monitor the blood pressure, reassure the client that finding is expected and can ambulate to the bathroom, administer a dose of prescribed methyl ergonovine. This is the way that they can ask this phenomenon that I explained, that because you assess the uterus is okay, the woman is stable, and the blood stopped coming out, you reassure the client that it is an expected finding and help the client to the bathroom. In relation with breastfeeding, well, we promote breastfeeding. Nursing promotes breastfeeding. The women have the right of refusing breastfeeding. You don't know, this is autonomy. But we promote with teaching breastfeeding because the advantages, the multiple advantages of breastfeeding. Breastfeeding is full of advantages. But the most important of all is the transference of antibodies immunity through secretory antibodies that appears in the breast milk. Because in reality, a part of that, the formula can supply. If you have money to buy the formula, the formula supply substitute the breast milk in everything except the antibodies. So the big difference is the antibodies. Um, women that are breastfeeding need to consume a little more calories than the usual and more fluids. Need to be very careful of keeping clean the nipple and to avoid skin breakdowns of the nipple. Uh, so avoid being harsh with the nipple when you clean it or dry. So clean only with water and but dry or leave dry to the air. Avoid the trauma when you move the baby from one breast to the next of trauma. So you need to break the suction with your finger, etc., etc. And a lot of hygiene, hand washing, etc., to prevent infection of that. This is the common question in English. Which one are the contraindications of breastfeeding? HIV and the consume of drug of addiction by the mother are the absolute contraindication for breastfeeding. This is tested when the woman cannot breastfeed. And a question, if a woman is a carrier of hepatitis B or C, can breastfeed? Yes, can breastfeed. Okay, as far of course there are no wounds in the nipples and blood in the nipples. Okay, so yes, a woman can breastfeed with hepatitis C or hepatitis B. Okay, this is a common a common question. Another question that you can have is classical in nursing. Okay, the baby is 100% breastfed. How the mother knows that is receiving enough breast milk? Well, the baby is well hydrated. The baby is gaining weight when the weight gain is expected. But the most important, you can know that if daily you need to change diapers 6 to 10 times. If the baby is wearing, okay, a diaper, okay, 6 to 10 times per day, then the baby is receiving enough fluid, enough fluid. I don't know if you know how to calculate urinary output in babies, in diaper babies. You need to know that the diapers have dry weight that can be told you, okay? Can be told you, okay? So if they say, for example, a dry diaper is weighing, for making it simple, let me see, 10 grams, 10 grams, when the diaper is dry. And when you remove the diaper from the baby that is already wet, no, because that's why we change the diaper, because it's already wet, is weighing 60 grams. How much urine is the baby? So you subtract the dry weight to the wet weight, and then you have 50, of course, and then you say 50 grams equal 50 milliliters. Okay, 1 milliliter of liquid is going to weigh 1 gram. So this is the equivalence. So if you have 50 grams of liquid weighing, okay, there in this wet diaper, okay, this is that. And then they can give you several diaper changes in your shift of 8 hours, and they can ask you how much urine output had this baby. You add, okay, the calculated urine of all the diapers that were changed in your shift, and then you add that and you put this number in the box of the question. So it is an English question. It is a common English question, how to calculate how much urine is peeing a baby. But the same logic is applied, that if you need to change the diaper because it's soaked 6 to 10 times per day, it's because the baby is receiving enough fluid through the breast milk. Because babies don't need water. Babies, you don't need to give water to babies. All the needs of water, of liquid of the babies need to be received either from the formula or the breast milk. In the mastitis, the most important is to understand that the mastitis doesn't contraindicate breastfeeding. The woman can continue breastfeeding, can for example, extract milk from this inflamed breast, and this milk is good, is not bad, is not discarded. And if the woman tolerates that, the baby can be, placed in this breast. When a baby is born, the first that you see of the baby is the head. 90% of the births are cephalic. So the first that you see when the baby is coming out from a normal vaginal birth, that is the entry-level nursing issue, what the first that you see is the head. Is the same, the first coming out. You need to know that immediately the head is out, the rest of the body is inside the vagina and the uterus of the mother. And not necessarily need to come everything in only one movement. Can come out first the head and then the rest of the body. When the head is out, okay, protruding out from the vaginal introitus, you expect that the person that is attending this birth uh, will clean the face of the baby of secretion, because the face comes full of secretion, and will suction the mouth and the nose of the baby. There is time for that. There is no reason to pull the baby to make the baby come out. So when the head is out, you are going to see the head of the baby, okay, coming out, and you have here the vagina. This baby, the face is clean with a sterile um, compresses, and with a pair that is usual in the kit for birth. You suction the mouth and then the nose. Why? Because you need to keep this mouth and this nose clean of secretions, of vaginal secretions and whatever, blood, etc. Because when in the next contraction, so the next contraction that the uterus is going to do to produce, probably the rest of the baby is coming out. And when the baby comes out, the baby will cry. The baby starts breathing air for first time when the baby starts crying. So usually babies uh, eh, are going to start breathing for first time, crying, and you want to have the airway clean for that purpose. Okay, it was an English question. If you understand this rationale, why you suction first the mouth because it's the priority, and then you have time the nose because when the baby cries and gets air through the mouth. This is the rationale of why you suction first the mouth, then the nose, and why you suction the mouth of the baby immediately the head is out. Because the what you need first when this baby is out, that the baby starts breathing for first time. The baby comes alive, the heart is beating, and meanwhile all this is happening, still the baby is receiving the oxygen through the placenta and the umbilical cord. So the baby in this moment doesn't need to breathe. But when the baby is out and is stimulated by the cold air and the touching, etc., the baby is not happy with that. Usually they are not happy with that. And the baby will start crying. And this is the way they start breathing. And it's the priority of a baby. The second priority, well, you know that sometimes babies are born with immature lungs that are not ready to breathe. This occurs mainly when the baby is a preemie, is a premature, and then you need to observe by the signs of respiratory distress in newborns that are the nasal flaring, very important. This opening and closing of the nostrils. The grunting is sound. This grunting is a sound that babies do during expiration, something like intercostal retractions, abdominal retractions. Those are signs of respiratory distress. Yes. So observe that the baby is breathing okay, because it's the priority of the baby when it's born to breathe. Once the baby is breathing, they clamp, okay, after a little while, the umbilical cord, and separates the baby from the mother, cutting the umbilical cord when you see that the baby is breathing spontaneously very well. Um, the, um, the next priority of the newborn is to prevent the hypothermia. So the first priority in a baby, a newborn, is breathing. And the second priority is avoid the loss of heat. I mean, the hypothermia. He or she is coming, the baby is coming from a warm environment, the interior of the uterus of the mother, and now comes out naked and comes out wet and is exposed to an air that is usually air with AC that is in what, in 96, 95, um, sorry, 96, 95, and much less is in how much you put the AC in the hospital. You put that in 75, 76. Okay, so those are okay the temperature of the AC. So notice that is at the risk of hypothermia. So how we prevent the hypothermia? Dry the baby, swallow the baby, cover the head and put in contact with the mother's skin. The mother's skin is warm, and then you put the baby in contact with the mother's skin, dry very well, and swallow the baby to prevent the evaporation. You dry the baby to prevent the irradiation of the heat. You swallow the baby, and to promote the transfer of warmth from the mother to the baby by contact. Okay. Um, you put the baby in contact with the mother. Okay, you avoid the baby being under AC outlet, etc., to prevent, okay, the convection, that is those raffles of air that can produce, okay, loss of heat. And you know that the babies will receive an antibiotic in ointments, is erythromycin, in the eyes as a routine, just in case the mother had in the vagina either chlamydia or gonorrhea bacteria. Is going to receive vitamin K because they can bleed. They can bleed because the trauma of the birth. They can bleed because the umbilicus, and they have deficient vitamin K because they have sterile intestine. And part of the vitamin K that the human has comes from the synthesis of the normal flora in the intestine. Uh, uh, the question in English is very stupid. You need to know the vitamin K in English is called phytonadione. So they use the word phytonadione, and they ask why the baby is giving a dose of phytonadione, which is the active vitamin K. Okay, and the answer is to prevent hemorrhage. So it is an English question. As you notice, it's a very easy question, because in reality, Nclex is not an unfair test. It's a test just asking you the entry-level knowledge that you need to have about a baby. Receive the hepatitis B vaccine. You promote bonding. And remember that we need to do everything possible for the adequate identification of the baby and all the interventions to prevent abduction of newborns. You know that sadly it is something that sometimes, very rarely, occurs. We need to do everything to prevent a baby from being abducted, from being stolen from the mother. Okay, so you need to teach the mother and to follow all the policies of the facility to prevent abduction of the babies. Okay, and one of the most important is to ensure that proper identification of the baby, and ensuring all the measures of the policies, the facility to prevent abduction. Remember that the vital signs of the babies after birth change are a little weird. The heart rate usually is between 110 and 160. Okay, so this is the range of the heart rate of a newborn. When they are sleeping, the heart rate is around 110, even can be 100. When they are crying, when they are active, then increases. But this is an important limit. The respiration can be as high as 60 respiration per minute. This is something can confuse sometimes if you don't learn this, that a baby with 60 respiration per minute is having a normal rate of respiration. The temperature is super important. Any temperature below 97.7 in a baby is considered hypothermia. So it is a value maybe to memorize, because if in a scenario the baby has 97.3, this baby has hypothermia, and of course requires immediate intervention to prevent this hypothermia to progress to a more severe form of hypothermia. So all those measurements that we mentioned here. So it's important to memorize this value, the lowest acceptable temperature in a newborn, because anything that is near this or below this requires intervention. The head circumference, okay, is in this range. It's very variable. The heads comes in very different shapes and sizes, but it is in this range, okay, and 32 to 37. If they want in the test to think in a too big head, they give you extreme value, 40 centimeters of head circumference. which is far beyond this top limit. And remember that this should make you suspect that the baby could have increased intracranial pressure. And the most common is hydrocephalus, excessive amount of cerebrospinal fluid inside the head. Remember that the blood sugar of the newborns is different. The normal blood sugar is different from the adult. The normal range is between 45 to 70 milligrams. It means that a blood sugar of 45 is normal. Okay, it's normal. Okay, if the baby has less than 45, what we need to do? We need to give early feeding, breast milk or formula, and recheck again the check. Okay. If the blood sugar is too low, then is when doctors will order the administration of IV glucose. But the intervention of a blood sugar, okay, between 35 and 45, which is low, but is not critical, will be feeding, okay, early feeding and monitorization. Only when there's very low blood sugar, and look at the value, 35, is when they give IV glucose. So early feeding is the way of dealing with a hypoglycemia. But don't forget that the same as the this 45 is normal. So you can use they can use a 45 blood glucose as a distractor. The bilirubin in a newborn is higher than in an adult. But usually the normal bilirubin, okay, is less than 6 milligrams. But it's common and it's not bad, it's not life-threatening, that after 24 hours, this bilirubin at the moment of birth will increase. It's what is called physiological jaundice. It occurs because immaturity of the liver of the newborn to excrete the bilirubin. So this physiological jaundice usually is below 14, 15 milligrams per deciliter. The physiological jaundice only requires increased fluids, so increased breastfeeding or formula, and phototherapy. We are going to talk about the different modalities of phototherapy. Don't confuse this with a topic that we already studied, that is the pathological jaundice that appears before the 24 hours, and the values are much more higher than these 14, 15 milligrams. That requires more intervention, as we mentioned before. The CBC of the newborns are very weird. The range of normal hemoglobin is too wide. It's extremely wide, from 12 to 24 grams of hemoglobin. So you can have a question which a baby has 19 grams of hemoglobin. Maybe you think that is not correct. Okay, it is okay. And the white blood cells are also in a very wide range of normality. Okay, tends to be increased. And they can even have 30,000 white blood cells per cubic millimeter, and it is not infection. It's a physiological level of white blood cells in a newborn. It can be used as a distractor. So what is the most concerning findings in a newborn? They put the white blood cell 29,000. And they say, oh no, this is an infection. No, not necessarily, because it's in the acceptable range of physiological values of CBC in the newborn. The Apgar scores is frequently tested. I don't think you need to memorize exactly the Apgar, but if you can, it's good. If you can, it's good, because if you work in an area, in the OB area, you are going to be using, the nurse is the one that usually practices the Apgar score. The Apgar score is done at the moment of birth, the moment the baby comes out, and 5 minutes later. So why is done twice? Very simple. In the moment the baby is coming out, the baby still is adapted to the intrauterus life. For example, you know that in the intrauterus life, the oxygen comes from the umbilical vein. and the umbilical vein drains to the inferior vena cava. So where is the oxygenated blood in a newborn, in a baby, in a fetus, in a baby, in a fetus, okay, inside the uterus, is in the right heart. The red blood, the oxygenated blood is arriving to the right heart. You know that we adults, we don't have oxygenated blood in the right heart. We have venous blood that is not oxygenated. So it's different. It's an example. So that's why babies need to have a hole that communicates the right atrium with the left atrium to make this oxygenated blood jump from the right atrium to the left atrium. And also any oxygenated blood that escapes this hole, the ostium primum, is going to have a duct, a tube communicating the pulmonary artery with the aorta that will bypass any oxygenated blood that passes to the right ventricles and to the pulmonary artery to the aorta. Okay, this is not important for the English, but it's to make your brain understand that the babies come different. It's like a transformer. You know a transformer, no? It comes like a car and transforms in the human, no? Okay. Okay, it's like a transformer. So it's coming at the minute with the intrauterus design. And quickly, in those few minutes, the baby starts crying. When the baby starts crying, the resistance to the blood flow in the pulmonary circulation decreases dramatically. Even the drop of the level of prostaglandins that are producing abundance by the mother, the drop of the prostaglandins is also participating here. What happens? The pressure in the left heart increases while the pressure in the right heart decreases. The hole between the atriums closes and the ductus arteriosus closes, and for first time air enters in the lungs and starts the gas exchange that is going to occur for the rest of the life. It happens in the first 5 minutes. That's why we compare how comes the baby to this world immediately after birth with what happens 5 minutes later. So what we are going to observe that the baby comes without breathing at the first minute, and 5 minutes later start breathing. That the baby maybe is cyanotic in the first minute and is pink in the upcoming 5 minutes. And a series of stuff. And this is the purpose. A common question in Nclex: what is evaluating the Apgar score? And they give you a distractor. If there is brain hypoxia, if there is a risk of brain damage, if the child is going to be have learning difficulties in the childhood, okay, and the right answer is evaluating the adaptation of the baby from the intrauterus life, intrauterine life to the extrauterine life. And this is what measures the Apgar score. And it is important. Apgar score can be between 0 and 10. It is important. Between 0 and 10. This is can be a range of value of the Apgar score. So this is the other one to memorize. If you have a baby that have an Apgar score between 0 and 3, this baby needs CPR. CPR, cardiopulmonary resuscitation. In newborns, the priority, the first in cardiopulmonary resuscitation is breathing, is airway and breathing. You know that in adults, it's not airway and breathing, it's circulation. Okay, in newborns, the priority is airway and breathing. So the baby is going to be intubated and is going to be artificially ventilated with ambu-vac or a ventilator if they have an Apgar score between 0 and 3. And of course, it's going to receive medication. If the baby has no heart activity, it's going to have chest compressions and is going to receive medication like epinephrine, etc., to stimulate the heartbeat. If the baby has an Apgar score between 4 and 7, this baby is depressed. It's very common that in the first minute, the baby is between 4 and 7, so needs help, but is alive. So this baby is having heart rate. This baby is breathing, maybe weak, but is breathing. What this baby is needing? Needs oxygen that is delivered through mask after suctioning carefully the mouth of the baby. So suctioning of the mouth without intubation, just suctioning the mouth, administration of oxygen. There is no need of ambu bag, just administration of oxygen through mask, drying very well the baby, and while you are drying the baby, you are touching the baby, you are stimulating the baby, and this stimulation makes the baby cry, make the baby breathe. So when you touch the baby with the towel, like the cloth that you are using to dry the baby starts crying. This is the level of stimulation needed in this question. So stimulate rubbing infant backs and butt while drying, and you can deliver suction and oxygen by mask. This is what is needed between 4 to 7. It's frequently tested. I don't know if you have an idea that babies receive a spank. Okay, it's spanked to make them cry. We don't do that. That is not necessary to spank the baby. Just rubbing, okay, the baby while you dry the baby, which is an important intervention to prevent hypothermia. You are stimulating, it's enough stimulation as to make the baby cry. So now the baby that is between 4 and 7 improve between 8 to 10, which is doesn't require intervention, a part of placing the baby with the mother to promote bond and to warm the baby. And this is tested. This is tested. What you do if the APGAR is 5, if the APGAR is 6, what you do if the APGAR is 9, what you do if the APGAR is 2 or 0. Okay, so CPR, stimulation in drying, and stimulation to make the baby cry, and nothing specifically except putting the baby with the mother. And this is what I suggest you to memorize. If you can memorize the average score, it's very useful. Okay? It's very useful. And it's very easy. You put these values in the top: 0, 1, and 2. Don't put 1, 2, 3. It's 0, 1, and 2. And here you are going to put 5 parameters. The first parameter is there is heartbeat, if the heart is beating. So the heart rate. The second parameter is the baby is breathing. Okay, breathe. Okay, the baby is breathing. Obviously, understand the most important. The two following parameters evaluate the nervous system. And one is how is the muscle tone, and the other how they react, is the word, how they react to the stimulation, to the suction, to the touching. Okay, is called the reflex irritability, how they react to the suction, etc. And the last is the color of the skin. If you have a baby that doesn't have heart rate, so is in cardiac arrest, you give it 0 for heart rate. If the baby has a heart rate, heart is beating, but has less than 100 heart rate, you give 1. If it has more than 100, you give 2. Breathing. The baby breathes, crying. So if you have the baby is not breathing, is not crying, is not breathing, you give 0. But if the baby has a strong cry, wah, 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 that oh yes, it's this very strong cry, you give 2. But if the baby has a weak, okay, cry, you give 1. Muscle tone is defined by the position of the extremities. Babies that are normal should have a totally flex extremities. So you see that the arms are totally flexed. Okay, the arms are totally flexed, and the lower extremities are totally flexed. Okay, this is the normal flexion that you put in a baby. If you have totally flexed, okay, good flexion, and of the extremities, you give 2. You give 2. If there is some flexion, no, not totally flexed, some flexion, okay, you give 1. but if you had totally flaccid, okay, extremities, totally flaccid extremities, no, it's like dead. It's like a rag doll, totally flaccid extremities, no, then you give only 0. Uh, the reflex reactivity is explored mainly when you suction the child, because you need to suction the child, and just you observe what the child is doing. If the child becomes very upset, start crying, coughing, sneezing, okay, so it's a strong reaction to the suctioning, you give 2. If the reaction is weak, like for example, weak cry or grimacing, okay, then you give 1. No reaction, give 0. And the color, if the baby is totally pink, including feet and hands, which is very rare, you give 2. It's very rare because this morning I was discussing that with someone. It's okay, is expected that newborns in the first days develop feet and blue feet and hands. It is called acrocyanosis. So having blue and persistent blue feet and hands is expected in the first days of life. The intervention is to cover those hands and so to swaddle the baby, because generally is a reflex normally vasoconstriction as a consequence of cold, you know. But it's okay, acrocyanosis. But if the baby doesn't have acrocyanosis, you give 2. If they have acrocyanosis, you give 1. If they are totally cyanotic, give 0. And then you add at the end, and you have the Apgar score. And the question that I seen in Nclex is generally the one related with the intervention depending on the Apgar score and what is the meaning of Apgar score. There's a lot about what is normal in newborns, what is expected in newborns. One of the most common questions is this sacral melanocytosis. Don't call this mongoloid, okay, spot. It's not mentioned as a mongoloid or mongol or whatever in English. It's called sacral because it's in the sacral area, the sacrum, and melanocytosis because the melanocytes are increased here, that are the cells that produce melanin, that is the substance that gives pigmentation to the skin, and it's called sacral melanocytosis. It's a gray, bluish discoloration of the buds, the sacrums, and sometimes the thighs that is found more frequently in Native Americans, Asians, and Hispanic, babies. Okay, so has a racial, okay, component and will disappear in the future. Um, Other findings are normal. The milia, that are those white spots, white spot in the face of the newborns because the excessive sebum in the skin, the deformities of the head because the molding of the floating bones of the skull. Lanugo, there is this hairy soft hair that is related with prematurity. Gynecomastia is normal to be seen in newborns. The Epstein pearls, which is a thickening of the gums, epithelial thickening of the gums that will disappear later. This is something that was in the test. This is normal, guys. It's called the Harlequin sign. Sometimes babies, you see that one half are red, are vasodilated, and the other half is pale. There is vasoconstriction. It's because a vasomotor instability. It is okay, no problem. Harlequin sign is okay. Okay. And you know, it's interesting, but it's not nothing wrong. This is a benign condition that is very common, the strawberry angiomas. Those are moles, those are birthmark, are congenital birthmarks that are formed by dilated capillaries, dilated blood vessels, and can be in any part of the body, are limited to the skin. They are not internal, are limited to the skin and are called strawberry angioma. Okay, have different classification, but in general they are called strawberry angioma or cherry angioma because the color. What you need to know about this, of course, parents are very concerned, but you need to tell that it's not related with nothing wrong with the baby. Nothing is wrong inside the baby. That is not any trauma. It doesn't hurt. It's not painful, and that the future of this mark is to grow. So it's going to become a little bigger as the baby is growing. But after a while, and talking about after several years, the immune system of the baby will start dissolving or shrinking the lesion and could shrink until it disappears, leaving a very light mark where the this hemangioma was present. Uh, if if for cosmetic reasons or whatever, doctors and the parents of the child decide to intervene, they have ways of also eliminating that, but has not any implication. There are other findings that are normal in babies. They have like an acne, okay, because the high level of hormones, okay, uh, of the babies. They are sometimes born with a lot of sebum in the skin. The Verni's caseosis is normal. You don't need to eliminate totally that. You don't need to wash until you only eliminate the excess, and little by little in the upcoming days and weeks, it is totally eliminated. Um, it's important to know what is meconium. Is the first um, a feces that comes from the intestine of the baby. The babies usually have a bowel movement in the first 24 hours of birth. And the first is the meconium. The meconium has a dark green color. It's not black, it's dark green color. Okay, if you observe the border here, there is a little amount is green. Is the normal color of that. There is a question in Nclex that is very interesting. How is the caca, is the poo of a child that is only consuming breast milk? It's very yellow, it's gold yellow, and has like a little curds, like a little just curds, milk curds in the consistency, and it's different from the breast from the formula feces that are more gray or cream color and are very stinky. The breast milk feces are more like yogurt smell, while the formula is much more stinky. The normal reflexes of the newborns are tested, if you know that are normal, and tend to disappear except the Babinski disappears around the third month of life. So there are primitive reflexes that will disappear when around 3 months. But there is one primitive reflex that is lasting 12 months, which is the Babinski. Moral reflex is called also startle reflex. That is when there is a noise or a movement, babies extend the upper extremities and makes like a Z, like an arc with the upper extremities. The tonic neck reflex, also called the fender reflex, because is like like a fending okay position. This sport that use spades. Uh, if you turn the head of the baby in one direction, the extremity to which the head is turned extends and the opposite extremity flexes. Gallon reflex has been in English, so please see that. If you put the baby prone position while you're examining the baby, you should not leave the baby in prone position because there's sudden infant death problem. No, you always should keep the baby in supine. But you put the babies in prone position and you stroke from up to down the side of the spine. The baby will contract the extremities and the trunk in the side, like making a C shape, no, like making an arc. Okay, in the side that you contract. It's a reflex that is normal. in the baby. The grasp reflex, if you touch the palm of the baby, will, hold what is touching. Even you can make the baby put the feet flat in a hard surface, can make steps. And the Babinski can be presented to you as a picture or can be described with words. Notice that is a, a dorsal flexion of the great toe with separation or fanning of the remaining toes when you stroke the sole of the baby. Normally, after the years, when you do this, is the contrary. The baby or the adult will flex all the toes when you stroke. This is the normal plantar reflex of an adult or a child of more than 1 year. But children before that age have this reflex. This reflex can reappear in an adult when there is damage of the upper motor neuron, like a stroke, etc. But it's not normal, it's abnormal. This is one reflex that once but mentioned one question is called parachute reflection. When the baby has before 6 months, a small baby, and the baby is falling, it has no way of defending. But after 6 months, the baby develops a reflex. This is not a learned, it's a reflex that when it's falling, when you make the baby like falling, you make the baby falling, approximating the floor or the mattress, they extend the upper extremities like to protect the head, and it's called the parachute reflex. They can give you a picture and ask you to click where you make a prick to obtain blood. Is in the shadow area, never in the middle. In the middle there is a nerve, and this is the cartilage that will form the calcaneus. You should not prick here. It's in the sides. And they can ask you, do you know what kind of diseases are explored in a newborn? uh, Guys, a newborn is systematically explored for near 30 different conditions. Some conditions are very logical, like for example, deafness. So yes, they explore if the baby is deaf. You can easily determine if the baby is deaf, is born deaf. Okay, so it is explored. The vision is not explored. Of course, they do a lamp examination of the eyes to notice that there is no cataracts, any abnormality. But the vision is difficult to explore because the vision in the newborn is very limited. They have a near vision, near sight. They cannot see beyond a couple of feet of distance. They cannot see anything separated from the face. But anything that is between 2-3 feet of distance can be seen, but very blurred. And they don't see colors during the first 3 months of age. They don't see colors. The color vision develops later, of 2-3 months. They don't see colors, and they see mainly the contrast between black and white. So anything that has dark and white colors side by side, so a contrast, as you see here in this screen, that you have white and black. No, the contrast is what they see much better. This question has been in Nclex recently very frequently. Many people have this question: the house sees a newborn. They don't see; they see in black and white. They will develop the color sight after 2-3 months. They see contrast. They have near vision. They don't see far. And yes, there is a have limited vision. It's normal to have some level of strabism. It's okay, and it will disappear in 2-3 months when the vision is developed, and then they have the capacity of fixation of the sight. And yes, they follow objects when they are 3 months, around the 3 months, okay, when they can follow objects. But they still can see, for example, recognize the face of the mother and some visible contrasting aspect. If the mother, you know, uh, paints with lipstick the mouth, they can see this contrast and they can react with the mother if the mother places her face near the face of the baby. The other condition that are explored in newborns is hypothyroidism, the congenital hypothyroidism. Okay, it is explored systematically in all babies. Congenital hypothyroidism is a possibility, produces mental retardation, the cretinism, and is easily treated with thyroid hormone. Let me leave these substances to last. Okay, congenital heart disease is screened in the newborn. The hip dysplasia is systematically screened in newborn. Okay. Of course, any other malformation is systematically screened. But there is a group, that's why I'm leaving that at the end, a group of metabolic diseases of the metabolism that are not common, are rare, but can produce mental retardation and can be treated, sometimes treated with diet, you know, that prevent the development of mental retardation. The best known is the phenylketonuria, PKU, in which the child is born with deficiency of an enzyme that metabolize the phenylalanine, an amino acid that all we have. And then for that reason, this amino acid builds up and is excreted a phenyl ketone in the urine and can produce mental retardation and is treated with diet. But there are a lot of other metabolic disease, the galactosemia, homocystinuria, maple syrup disease, the MCAD, etc., that are also explored. So there are a lot of diseases that are explored systematically in newborns. We already talked about the jaundice, but what is interesting about phototherapy, to know about phototherapy, is that in the phototherapy, the baby should be naked, only covering the eyes and the genitals. But because the more skin that is exposed to the light, the more elimination of the bilirubin occurs. The light promotes the conjugation of the bilirubin in the skin, which is a chemical phenomenon, and this conjugated bilirubin cannot go to the brain where it could produce damage, the kernicters, and is excreted in the feces and the urine. For that reason, the feces and the urine becomes discolored with a green yellowish color. So warn the parents that it's okay, it's normal to see the urine and the poo of the baby like green. And this increased excretion of bilirubin through the feces make the baby has a little loose stools, like a very mild diarrhea, okay? Loose stools. When the baby is having jaundice, it's necessary to be fed with milk more frequently, uh, either breast milk or formula, because the increments of the hydration with this is going to favor the elimination of the bilirubin. There is never apply lotions, oils, etc., in the skin of the babies that are going to be exposed to phototherapy. It's very important because it can produce burns in the skin. And if the doctors only order sunlight at home, sunlight, it is going to be a very short exposition, around 30 minutes, 15, 30 minutes, 2-3 times per day. And the light is not directly under the sunlight. It's not that you are going to take the shower outside under the sun. No, it's indirect sunlight, like for example, in a window, and preferably between 10 a.m. or after 4 p.m., which is the adequate hours of receiving sunlight at any age. Yeah. And when it is in the hospital, they use these lamps that keep the child warm, and at the same time, okay, produce the phototherapy. But every 2 hours, you need to take the baby out, remove the eye cover, and provide, okay, feeding, the feeding. There is a variety of phototherapy that you need to know that is used each day even more. It's called blanket phototherapy. Are blankets connected to energy, to electrical energy that produce the light, and then you wrap the naked baby, uh, only with a little diaper, uh, in the blanket. You see that here in the picture. In that case, because the light is not going to affect the eyes, there is no need of covering the eyes if the technique of the blanket of phototherapy is used. And there is a recent question that appears in Nclex that moved me to include this concept. There is a very rare disease. It's a metabolic disease. It's the disease of this group, okay? It's a metabolic disease called porphyria. In the porphyria, if a baby is born with this condition, the phototherapy is contraindicated. They need to deal with the bilirubin with other methods different from phototherapy because will produce a severe burning of the skin. Was I dance with the music that I hear, and somebody commented me that had this weird, rare question in their anchors, and then I report that. Remember that for the umbilical cord, that you expect that around the 10th days is going to fall, and the only concern is that could become infected. So any fevers, purulent secretion, red skin should be reported. And it's important to keep the diaper folded to avoid covering the umbilical cord because it's going to produce maceration. If you don't use alcohol, only the normal, sponge bath of the baby until the umbilical cord is false, and nothing special with the umbilical cord. When the umbilical cord falls, it's normal that a little amount of blood ooze, okay, some drop of blood ooze there. There is no concern. So warm the clients, the parents, is not going very bad. If there is circumcision, the two questions that are more frequent in Nclex about circumcision is that they don't provide anesthesia during circumcision. It is evidence-based practice. There's not any cultural, religious, whatever reason. Is that the risk of anesthesia, even local anesthesia, is very high for newborns and is not justified to provide anesthesia for the circumcision, for the level of pain of the circumcision. And for this procedure, to minimize the pain of this procedure, or any other procedure, like for example, needle stick of the heel, is enough to give a pacifier to suck by the baby with glucose or sucrose. And this has been by research, demonstrated that it provides at this age enough analgesia uh, for these minor, moderate painful procedures. The other teaching is that you need to keep the PP covered with a petroleum gas to prevent the diaper from adhering to the wound, and that the wound will form normally a yellow crust that is not pus, it's normal healing in the circumcision. The priority in a circumcision is to be sure that after the circumcision, the edema, the potential edema that is producing, is not impairing the urinary output. So what you observe of the baby after circumcision, that is peeing. If the baby is peeing, no problem. It is no problem. It rarely is becoming infected. This is not a common infection, and rarely bleeds. So no problem in this aspect. Okay, those were some of the topic that I was wanting to comment to finish. Okay, what has been in Nclex about this. I like because the command that I have is to go over again in a new cycle of content. Because remember, Nclex is 80% content. Just a moment, guys. Okay, what is recording? Record from current slide. Okay, is 80% content, your knowledge, basic knowledge, no specialized knowledge, basic knowledge. And the other 20% is common sense, how you apply this knowledge. So it's important to make a review of content because you know when you finish the career, some of the stuff that you studied at the beginning, like anatomy and physiology, like fundamentals, is forgotten. And especially in those accelerated programs that you do because you want to graduate very fast. And it's important to make a review of content. For example, they ask a lot of questions. If you know the blood test, the blood work albumin is the most frequently used test to evaluate the nutritional state of somebody who is sick. Suppose that you have somebody who is sick, somebody that has, I don't know, diabetes, somebody that has renal failure, somebody that is sick, and the doctors want to know how is the status of the nutrition of this person. The most commonly test done is the albumin. Now they are going to give you the values of the test, but it's useful to know the albumin has the same normal value as the potassium, 3.5 to 5. So the problem when the albumin is low, is below 3.5. It means that the person has a proteic malnutrition. And as a consequence, any effort to recover from a disease will be impaired by this deficiency of nutrition. To recover from a disease, to recover a pneumonia in the lungs, to recover a fracture in the bone, to recover the wound of a surgery, you need proteins that are the bricks that allow you to build new walls and new tissues. And if you have malnutrition, then it is going to be impaired. One of the most commonly tested topics about this is wound healing, especially chronic difficult to heal wounds like the pressure ulcers, in which having a low albumin is a risk factor to have a delayed or impaired process of healing. It is true that the pre-albumin is a variety of tests that is even better than the albumin because it's affected earlier than the albumin when the malnutrition develops. But because it's very expensive and all of the labs do, doctors continue depending on the albumin for this evaluation. So how it can be tested? Which of the following factors are the most important in a client with a pressure ulcer in the sacral area? And then they give you albumin 2.8, which is below the 3.5. And this is the answer, okay? It's very easy, questions in which you correlate albumin with nutrition. Other aspect that I think you should memorize is the normal BMI. To avoid forcing your memory, memorize 18 to 25. It's enough with that. It's useful to know the normal BMI, the normal weight in relation with the height, because it's in many questions. For example, they can ask you in which angle you administer a subcutaneous injection in a person with a BMI in 18, and necessarily need to be 45. Because a person that has BMI 18 is thin, has little adipose, subcutaneous. And if you enter perpendicular in 90 degrees, which is another option in subcutaneous injection, you can reach with your needle the muscle. And now the shot will be intramuscular, is not subcutaneous. It's an example. It's just an example. Okay, is an example. So there are many situations in which they to understand the question that is asked, knowing the normal range of the BMI is useful. So I recommend you to memorize the normal range. You need to know the vitamins are frequently tested in Nclex. And you need to know that the vitamins have different names to the one that you know. And in Nclex, for a reason that I don't understand very well, they like to use those names. So for example, vitamin A, that has so much to do with the vision, also is called retinol, retinol, see? And it is the other name. Vitamin D has been presented as cholecalciferol. When you see the calcium and knowing the vitamin D is especially related with the calcium, maybe you recognize that. I already mentioned that vitamin K frequently is called phytonadione because it's the active form of the vitamin. The vitamin B1 is the thiamine, the B3 is the niacin, B6 pyridoxine, folic acid or folate is the same. Vitamin B12 is also called cyanocobalamin, and vitamin C ascorbic acid. So it's useful to be familiar with the other names of the vitamins because by reports that I receive could be used in your anchors. Vitamin A are present in orange colored and dark green vegetable. So trying to think in something that is orange. So if they say cantaloupe, if they say ¿cómo se llama? Sweet potato, pumpkin, carrots, okay. Dark green, okay, thinking dark green vegetable, also rich in vitamin A. And liver is very rich in vitamin A. The deficient vitamin D is mainly related to problems in the vision. Has other implications, but we don't need to go too deep. It's just the most important. And remember, there is a medication for acne, which is a form of vitamin A. It's a derivative of the vitamin A, which is the isotretinoin. Remember that it's teratogenic. Okay, is can produce malformation. Uh, those vitamins that are in these sites are soluble in fat. Those vitamins are soluble in water. The vitamins that are soluble in fat, especially vitamin A and D, can accumulate in the fat tissues of the body, in the fatty tissues of the body. For that reason, it can become toxic. Vitamin A can become toxic in the brain, producing a increased intracranial pressure. Vitamin D can become toxic, producing too much calcium that produce damage in the kidneys, because when there is too much calcium, the one that is going to pay the bill are the kidneys, can be damaged by the excess of calcium, by the hypercalciuria. The vitamin D is so important, is so frequently tested, because vitamin D is very complex. Vitamin D is indispensable to have a normal level of calcium and phosphorus. And you know that both are important, but especially the calcium. Alteration in the level of calcium, so the hypocalcemia, can be even life-threatening because the hypocalcemia can produce cardiac dysrhythmia, like Torsado the point, can produce seizures, can produce muscle spasm, etc. And of course, the strength of the bones depends on the calcium. So it's so important, the vitamin D. Vitamin D requires two activations. The vitamin D is ingested as a provitamin that is inactive. And this provitamin that is abundant in fortified milk and dairy, in fish, like salmon, cod, tuna, in the yolk of the eggs are the good sources of vitamin D, but especially in fortified dairy, uh, is ingested inactive and requires two activation. One in the skin under the action of the ultraviolet light, and the other activation occurs in the kidneys. So when you can have deficiency of vitamin D, well, the first is that you don't consume vitamin D or you don't absorb vitamin D. You know there is a condition in the intestine that is called intestinal malabsorption that is seen in celiac disease, Crohn's disease, etc. And when there is malabsorption, appears a phenomenon called steatorrhea. Steatorrhea. And the steatorrhea is that the fats that you intake, the fat that you eat, are not going to be digested in totality. Part of the fats are not going to be digested and absorbed and appears in the feces. Remember that this is a fat soluble vitamin. So the steatorrheas will produce deficiencies of the fat soluble vitamins, because if you don't absorb the fats, you don't absorb the fat soluble vitamins. So the one cause of vitamins, fat soluble vitamin deficiency, including vitamin D, is malabsorption, celiac disease, steatorrhea, Crohn's disease, etc. The other is that you are not exposed to ultraviolet light. There are people that work at night, people that live in the Arctic, okay, people that has lupus and cannot receive sunlight, etc., etc. Skin cancer and they can resist sunlight and they use overuse the sunblock, etc., etc. Those people are having less ultraviolet light to activate the vitamin D. But this is very important. There are people that don't have kidneys, are in dialysis, have end-stage renal disease. The kidneys have been fried by diseases, and those people cannot activate the vitamin D. So either a person that has a decreased intake of vitamin D, absorption of vitamin D, a person that is not receiving enough ultraviolet light, or a person that has kidney disease can have deficiency of vitamin D, and this is tested. The deficiency of vitamin D in children, in humans that are growing, produce something called rickets. Okay, rickets. In America, it's very rare, but in the third world, it's common. Rickets. But the deficiency in adults is more frequent because, as I said before, there are adults that cannot receive ultraviolet light, and there are adults that don't have kidneys. When the deficiency of vitamin D occurs in adult, it's called osteomalacia. Okay, osteomalacia. Rickets in children, osteomalacia in adults. Low calcium, and because the calcium is low, high phosphorus in the blood. And why? Because no vitamin D, no active vitamin D. So a client in dialysis probably has osteomalacia. A client with lupus that is not taking care of that, or a client that has gastric bypass, etc., can have osteomalacia. See, client with steatorrhea can have osteomalacia. Yeah, clients that are not consuming, okay, vitamin D can have osteomalacia. The consequence of osteomalacia is that the bones are brittle, the bones are weak. Don't confuse the osteomalacia with the osteoporosis. At the ends, it's like the same, are brittle or weak bones, but there is a difference. You don't need to go so deep. You are not going to be an osteologist, but you need to know that the osteoporosis is not because deficiency of vitamin D, is because deficiency of estrogens, and it's a condition that happens mainly in women after the menopause as growing old, osteoporosis. So it's the lack of calcium because you also need estrogens to put the calcium in the bone, osteoporosis. The osteomalacia is deficient vitamin D. At the end, it's the same, brittle bone. And what is the problem of brittle bone? That risk for pathological fractures. And what a nurse need to do, avoid falls, avoid trauma. So you need to be aware that either with osteoporosis or osteomalacia, the client is at risk for injury, risk for fractures, and all the implication that has, okay? But this is an important interpretation or analysis of the deficient vitamin D that a nurse need to have clear to understand the questions, understand the question. And that's it. But the contrary, when clients take too much vitamin D because are consuming over-the-counter vitamin D in excess, they can develop hypercalcemia, and the hypercalcemia can damage the kidneys, producing kidney stone on calcinosis. Vitamin K, remember the other name is phytonadione, and remember that this vitamin K is needed for the normal coagulation. A normal liver takes the vitamin K that you absorb from your intestine. The vitamin K can be ingested, can be eaten. And you eat that especially when you eat vegetables, green leafy vegetables. Okay? Green leafy vegetables. So vegetables that you eat the leaf. Okay? And try to imagine all the green leafy vegetables. And you absorb this vitamin K. But also an important percentage of vitamin K is synthesized, is produced not by a plant, it's produced by the bacteria that you have in your intestine, your normal flora. And is it can something that you don't change. Uh, the vitamin K is used by the liver to produce substances that are inactive, circulating in the blood, called certain coagulation factors. And those substances can be activated when you have a wound, and the wound breaks a blood vessel, and the blood vessels start bleeding. This activate a cascade of coagulation that initially includes the substances released locally there in the wound, then the activation of the platelets, and then the activation of the coagulation factors, forming a plug of fibrin that stops the bleeding. So this is coagulation, and the vitamin K is important for that. You know that there is a medication used to decrease, to reduce the capacity of the blood of forming clots. It's called warfarin. That the mechanism of action is the warfarin kills, inactivates part of your vitamin K. It depends of the dose. If you give too much warfarin, you kills too much vitamin K. If you give too little warfarin, you kill too little vitamin K. So the ideal is not giving too much, neither too much nor too little. It's giving, okay, the adequate amount. And you know this measuring the PT and INR. Okay, so keeping the INR between 2 and 3 is neither too little nor too much. It's the adequate dose. Okay, this is the understanding of the warfarin in relation with vitamin K. But if you start being the client taking the warfarin to the specific dose that keeps the INR between 2 and 3, is messing, is irregular in the intake of green leafy vegetable, then you are going to have a fluctuation of this action depending on the amount of vitamin K that you are consuming. For that reason, you need to teach the client to have a constant intake of green leafy vegetable to have an adequate, steady treatment with the warfarin, of the anticoagulation with warfarin. When we want to give warfarin to a person, when we don't want clot forming in excess, like clients with atrial fibrillation, clients that has history of DVT and pulmonary embolism, etc. Vitamin D is rarely tested. The only interesting question that in my life I've seen about vitamin E is that high doses, mega doses of vitamin E, that some people consume the mega dose of vitamin E because they say that it's antioxidants, delayed aging, etc. Okay, is that they can inhibit coagulation. So when could be important this detail? Well, somebody's going to surgery and confess you that is taking mega dose of vitamin E. You need to warn doctor. Doctor, maybe this client is bleeding too much during the surgery because it's consuming mega dose of vitamin E. or the client is prescribed warfarin, but also is taking over the counter megadose of vitamin E, or you can say it is can interact. Okay. The vitamin B1 is the vitamin of the alcoholics. Alcohol metabolism requires thiamine for this metabolism. So to eliminate the alcohol that we drink, we need vitamin B1, thiamine. But also the neurons of our brains requires thiamine for the normal metabolism of the neurons and the production of ATP. So now, if you are alcoholic, you have a competence between the needs of the alcohol metabolism and the needs of the neurons metabolism in relation with the thiamine. So deficiency of thiamine can appear because they consume the thiamine by the metabolism of the alcohol that the person is intaking in excess. And this can produce damage in the brain. That is the famous Wernicke-Korsakoff encephalopathy. And is treated with thiamine. That's why the question that you can have is what is the most important vitamin to be given to an alcoholic client is thiamine, and is to prevent precisely this brain damage. Okay, so when an alcoholic arrives to the ER, what they give, the two things that immediately the client is missing: glucose. Remember that the alcohol produces hypoglycemia. Maybe some of you don't have this knowledge. Alcohol, okay, so the bar, the alcohol it produces, ¿cómo se llama? Hypoglycemia. You need to give glucose and also thiamine. That's why they give those banana bags, no? Those IV fluids that have a yellow color because the thiamine. The only interesting about niacin is used by the doctor to manage cholesterol. Some clients, especially clients that have low HDL cholesterol or good cholesterol, are prescribed niacin. Niacin is given in mega doses for the cholesterol, and these mega doses produces flushing. And this flushing can be blocked if you take a baby aspirin before taking the niacin. Pyridoxine is the only interesting about pyridoxine is the deficiency of pyridoxine produces neuropathy, peripheral neuropathy. The peripheral neuropathy is producing numbness, tinglings in the hands and the feet, and of course muscle weakness and impaired gait. So those clients that have deficiency of vitamin B6 require supplementation of this. There is a medication called isoniazid, which is the cornerstone of the treatment of tuberculosis, that needs supplementation of pyridoxine to prevent the neuropathy that tends to produce this medication. Folic acid, everybody knows that folic acid is needed during pregnancy, before and during pregnancy, to prevent neural tube malformation. But also folic acid is needed to produce hemoglobin and red blood cells. If for any reason is a deficiency of folic acid in a person, this person can develop anemia, even if have normal iron. Okay, because the most common form of iron is because deficiency of the most common form of anemia is deficiency of iron, but also deficiency of folic acid can produce anemia. It's a little different. It's an anemia that has big red blood cells, just a few, but are big red blood cells. It's macrocytic. Okay, it's macrocytic. It's very rare to have deficiency of folic acid. It's extremely rare to have deficiency of folic acid. Why? Because it's abundant in the food. Vegetables, meats, etc., have a lot of folic acid. And it's very rare that a person have this level of malnutrition that can have deficiency of folic acid. Who is the client that in American society is presenting malnutrition more frequently? Alcoholics client. The alcoholism is frequently associated with malnutrition for several reasons. And for that reason, alcoholic clients can have deficiency of folic acid. Of course, there are certain medications that can inactivate the folic acid. So people that must take chronically methotrexate, a medication that you should know is used as an immune suppressors in patients with rheumatoid arthritis, psoriasis, etc., could have deficiencies of folic acid. That's why this medication is given with supplementation of folic acid. The vitamin B12, also called cyanocobalamin, is a very complex vitamin also because is abundant in the animal food. So any person that eat meats of any kind, okay, includes fish, poultry, beef, etc., or any person that consumes milk and dairy, any person that consumes eggs, have plenty B12 in his or her diet. Maybe the vegans, strict vegans, after a while, after several months of being vegan, almost a year of being vegan, could develop deficiency of B12, but it's very rare because the vegans are educated and they know that they need to take supplements of B12. The problem with the B12 is when the person has a disease in the stomach, this bag that we have inside the belly, produces a protein needed to absorb the B12. It's called intrinsic factor. Sometimes people have the stomach removed because cancer, because ulcers, or bypassed in the bariatric surgery to loss of weight. But sometimes the stomach is just old, is atrophic, has atrophic gastritis, could be autoimmune or because aging. So A, B, or C reason, the stomach is not working properly, and for that reason, intrinsic factor is not produced. And no matter how much B12 you eat, you consume, you intake, is not going to be absorbed because there is not the needed protein to absorb the B12. And then the B12 is going to end in the feces, in the poo-poo. Those people need to have the B12 administered in shots. Because if you administer, you force the vitamin B12 in a shot, intramuscular shot, then you don't need the absorption because you are bypassing the absorption. Those are the people that require shots lifelong of B12. What happens if you don't have B12? Two things happens and need to be very clear. B12 is needed for two purposes. First purposes, to produce red blood cells, hemoglobin and red blood cells. So also, the same as the folic acid, the deficiency of B12 produces anemia. Anemia of big red blood cells, okay? Macrocytic anemia. Just a few red blood cells, but big. In contrast with the iron deficiency that produces small red blood cells, microcytic, okay, anemia. But the other problem with the B12 is needed for the formation, the synthesis of myelin. And neurons and peripheral nerve must have myelin to work. If there is deficiency in the synthesis of myelin because deficiency of B12, the neurons of the brains start failing. And generally cognitive problems will appear, loss of memory, reasoning, etc. So a dementia can appear in people that have deficiency of B12. So imagine that you have deficiency of B12 because you have a gastric bypass and you develop dementia, like an Alzheimer's, similar to Alzheimer's. So now you understand how serious is the B12 deficiency, but also develops peripheral neuropathy. So the person start having problems to walk, problems to have equilibrium, problems to feel in the feet, etc., etc. That's why people that develop this anemia associated with brain damage is called pernicious anemia. Pernicious means very bad, and exactly is the meaning of this term. Vitamin C is frequently tested if you are aware that it's needed for the healing process. When you have a wound, any kind of wound, a fracture, a, ¿cómo se llama? A burn, a pressure ulcer, a surgical wound, a part of proteins to repair those tissues, to reconstruct those tissues that have been damaged, you need vitamin C, ascorbic acid, for the synthesis of collagen. Collagen is the main protein that seals or fill those wounds or those defects. So that's why it's needed for the healing. All those vitamins have been in your ankles, not your vitamins. You need to know a little about therapeutic diets. For example, you need to be able to recognize what is a clear liquid for a clear liquid diet. Clear liquid diet is used in patients going to surgery until 2 hours before the surgery. Clear liquid diet is used after the surgery to see if the clients tolerate the the intake without vomiting. Clear liquid diet is used in preparation for certain intestinal exams like colonoscopy, etc. Okay, and is frequently used. Okay, so you need to know that any substance that is liquid at room temperature and allows the light to pass, like gelatin, broth, bouillons, popsicles, coffee without cream, tea, apple, or cranberry juice, are examples of clear liquid diet. If milk, dairy, or purees or opaque juices are added, now it's full liquid. You need to be knowledgeable about how to calculate the oral liquid intake of a person. Uh, so you're working as a nurse. You will have your help, that is the UAP, the unlicensed assisted personnel, or CNA, reporting you how much liquid had a client in your shift. The CNA will report that in ounces. Remember that talking about the fluid ounces. There are two types of ounces: weight ounce and fluid ounce, and they're totally different. If you go to buy, I don't know, uh, beans or coffee, you see the package says, okay, it has 16 ounces, has 8 ounces. Okay, it is weight ounce. It is not used in this calculation, but it is another ounce. It's called fluid ounce, which is a household measurement unit that is equivalent to 30 milliliter. And the other equivalent that you need to memorize is 1 cup, which is 8 ounces. 8 times 30 is 240 milliliters. So those equivalents need to be memorized, because the CNA will tell you the client had 1 cup of soup, it is liquid. It had 1 cup of orange juice, it is liquid. Has 2 cups of water, it is liquid. So you need to be translating each cup in milliliter. So 1 cup of soup, 240. You write 240. 1 cup of juice, 240 more. 2 cups of water, 2 times 240, 480 added. And then systematically, maybe the nurse is, the CNA is telling you, and also has 1 ounce of gelatin. Gelatin is liquid, okay, you put 30 milliliters. And 2 ounces of milk, and then is 60 milliliters. And then at the end, you add, if you calculate all those milliliters, and this is the number that you are going to introduce in the box that you will have in your ankles, okay, after they gave you this information. Guys, if you not understanding something that I'm explaining, stop me and ask, okay? So what are the tricks? What are the tricks? The tricks, okay? They can put a banana. So the clients drank, the clients had 1 cup of milk, 1 cup of orange juice, 2 cups of soup, 1 ounce of gelatin, 1 banana, 1/8 ounces banana, and etc., etc. So this banana, so in my experience as a professor, the student get confused with the banana. This banana is ignored, discarded in your calculation of the liquid, because banana is not a liquid, it's a solid. Yeah. And the ounces that weigh the banana are weight ounces, is not included in the fluid ounces that we need to use for the calculation of the oral intake. So this is one of the most common source of confusion in the students that have been sharing with me experiences when they go to the anchors. The anchors put solid food that also weigh. Solid food weighs, okay? Solid food weigh, okay, ounces, but are weight ounces, not fluid ounces. So you need to discard, you need to eliminate anything that is solid, okay? So, professor, I had a very question, difficult to understand. I don't know how to how many ounces is a banana. Your banana is not a liquid banana, it's a solid. You ignore the banana. Nevertheless, some students very rarely had this equivalence, which for me is very tricky. How many liquid has an orange? Because you know, when you intake an orange, it's considered liquid, or a grapefruit, the same situation. Because you know that our fruits that produce a lot of liquid, so are included in the fluid intake calculation. So one orange is a sector that has 1/3 of cup, which is around 80 milliliters, and one grapefruit, 3/4 of cup, that is around 180 milliliters. I don't think it's going to be in your anchors. And even if you're in your anchors, you can give away this question to your anchors. You are not going to fail. But if you have good memory, it's not bad to know how much liquid provides one orange and one grapefruit. The other detail, if you have ice chips, okay, there is air between the chips, and you need to reduce the volume. If there is 1 cup of ice chips, a patient consume 1 cup of ice chip, reduce that to half, because when they ice chips melt, the air is going to be expelled, and the real is going to be 1/2. So in reality, it's a 1/2 cup. So remember that puree, banana, applesauce, etc. are not liquids, are distractors. Okay. When you see this term in your English, mechanically modified or pureed diet, consider equivalence. Maybe it's a little different, but consider this equivalent. When a person cannot chew, you have a steak, you have a T-bone, you can, enjoy the T-bone because you have good teeth, good masseters, good chewing capacity, with good swallowing capacity, and you enjoy with your piece of animal, no? But there are people that have problem to chew because of fractures in the jaw, or because they don't have teeth, or because they have dysphagia. In those clients, we use the food mechanically modified. It's the same T-bone that has been grind, that have been giving us a ground beef. Or is the same, I don't know, qué sé yo, beans that have been pureed. You understand? This is what means mechanically modified. It's the same food, the same nutrients, but now has been pre-chewed, no? Pre-chewed. Usually in 99% of the diseases that we study, the diet should be high in proteins for the reason that I explained, to repair the tissues. But there are two exceptions. When you have extremely severe, like decompensated cirrhosis, extremely severe, because a normal cirrhosis, a stable cirrhosis, have a normal protein diet. But extremely severe decompensated cirrhosis, or a client with kidney disease, advanced kidney disease that is not yet in dialysis, then you can have a doctor ordering a reduction in the amount of proteins. because proteins produce ammonia and urea. In extreme severe decompensated liver disease, the ammonia elevates. And the ammonia comes from the proteins. That's why they can transiently decrease the intake of proteins. And in clients that have renal disease and are not yet in dialysis, have no artificial kidneys, then they need to reduce the amount of proteins to minimize the production of urea and to avoid the overload of the kidneys. Gluten-free diet is super frequently tested. I don't justify anybody failing this diet, because only four grains, only four foods have gluten. Celiac disease needs gluten-free diet. And the grains that have gluten are barley, rye, oats, and wheat. Barley and rye are rarely used and rarely mentioned, but who knows? Okay, because there is a rye bread, which is not so rare. Okay, and barley is used for beer, so that's why beer is not convenience in celiac disease, because we use barley to make beer and rye bread. But the one that is super frequently consumed is the wheat and the oat, because a lot of stuff of foods that we have normally have wheat. A hamburger has wheat. Why? Because a hamburger has a bun. What is a bun? Bread. And bread is made with wheat. Uh, a, a chicken soup, traditional chicken soup has wheat. Why? Because usually chicken soup has noodles. Yeah, has noodles, and the noodles are done with wheat. Yes. So even even for example, a meatloaf, a meatloaf, a breaded chicken. Okay, to make a meatloaf, to make a how you call meatballs, you frequently add bread crumbles to the meat to make this kind of food. So you need to have a minimum culture, culinary culture, uh, to understand the Nclex question. Because, for example, meatloaf has been in the Nclex. A chicken soup has been in the Nclex. Okay, and you need to know that the frequent that wheat is in breads, crackers, noodles, pasta, combined with hidden, okay, in even mayonnaise is thickened with flour. Cake has with flour, etc. Oats is more limited because oatmeal and oat cookies are the one that you usually consume with that. But be aware. So understand that a client with celiac disease can never, forever consume gluten, because this, if they do that, the disease will be reactivated. Instead, they can consume anything that is not this. So I always was shocked that when I used to teach in the school, I put in my test classically if a child with celiac disease could consume corn flake. And more than 50% of the class say, no, cannot have corn flakes. You guys, what is corn flake? Corn is corn mentioned in barley, rye, oats, and wheat? In any moments I mention corn. No. And why you said that the clients cannot have cornflake? So please take care that quinoa, rice, corn, or anything that is not barley, rye, oats, and wheat can be consumed. High potassium, low potassium diet can be tested. Remember that a client taking diuretics should have a high potassium diet. Um, so this is the most frequent reason for giving a high potassium diet. Fruits, especially tropical fruits. Here is a list of fruits. The majority of those fruits grows in the tropics. Avocado, cantaloupe, orange, tomato, banana, mango, papaya. Those are tropical fruits, are not the fruits of cold weather. Yes. If those fruits are dried, okay, like raisins or plums or dates or figs, the potassium is concentrated. The skin of potatoes and sweet potatoes is very rich in potassium. Beet greens, beet greens. This is beet greens. Okay, even the milk is very rich in potassium. Okay, so it is recommended to a client that is taking diuretics. But low potassium is indicated in clients that have, for example, renal disease. Clients with renal disease should have a diet low in potassium because they have the tendency to elevate the potassium. And sometimes clients are taking medications that elevates the potassium. Like, for example, spironolactone, a potassium sparing diuretic. Even the ACE inhibitors, Pril, no, the Pril medication. In that case, the intake of potassium should be the normal, not increase. So you need to warn the person to, for example, if they are going to have fruits because they enjoy fruits, to prefer fruits from cold weather. Apple, pear, peaches, berry, cherries, grapes are fruits from cold weathers that classically are mentioned in a low potassium diet. It's super important that people that requires low potassium diet avoid salt substitutes. Salt substitute is not salt because it's called salt substitute. It's not salt. It's something that substitute the salt when you have prohibited the intake of salt, of common salt, of table salt, which is sodium chloride. The salt substitute is something that gives a salty taste to the food, but it's not salt. In reality, it's potassium chloride. So the salt substitutes contain potassium and should not be used if the client has a low potassium diet. If you don't have renal disease and you are not taking any medication that elevate potassium, you can perfectly use salt substitute, no problem. But if you are in a low potassium diet for medical reasons, should avoid salt substitute. There are other foods that are low in potassium that is not harmful, is not going to harm you if you read a couple of times um to cómo se llama to remember that. Okay, zucchini, yellow squash, okay, etc. The low sodium diet is frequently tested. If you are able, if you are competent to educate a client with edema, with heart failure, in a diet low in sodium. So I think that's very easy because anything that you buy processed in a container in the supermarket, practically everything has sodium. So what is free of sodium? Well, anything that you buy raw, natural. If you buy a lettuce, if you buy a carrot, if you buy a pumpkin, if you buy a potato, if you buy general, no, the majority, if you buy meat, etc., and you prepare from scratch, and you don't add salt when you are cooking this stuff, it is a low sodium diet. So for me, it's very easy. The only interesting in that I discovered that is in English, take care, that was a surprise for me, is the uh, canned fruits. You know that apples, peaches, pears can be canned in syrup. Okay, the cans, ¿cómo se llama? Canned fruits are low in sodium, are zero sodium, and also low in potassium. Low in potassium because those fruits are low in potassium. Okay. What else I learned? That the milk, okay, and dairy is very high in sodium and very high in potassium. I also learned this when I studied this, and because it has been in English. Okay. Of course, everybody know that processed food, soups, baked foods, pickles, uh, the commercial dressings are very rich in sodium. Okay, here you have a high potassium food, a collage. to create visual memory. So of course, banana. But banana is so easy that it's rarely in the test. Banana is for latex allergy, but cantaloupe is useful. Okay, kiwi, mango. Notice that majority of those fruits are ¿cómo se llama? Are tropical. Dry fruits, etc. Vegetable. Look at sea salt substitute. Okay, very rich in potassium. Milk. Okay, and low potassium. Okay, cold weather fruits. Okay, fruits that do not grow mainly in cold weather. Some vegetable, etc. Okay. Tyramine is restricted in patients taking monoamine oxidase inhibitor. You know that, you studied that. Tyramine is present in food that has been aged. What is wine? Is fermented and aged grapes. What is beer? Fermented and aged barley. What is a Swiss cheese? A cheddar cheese, a fresh cheese that initially was white and then was made mature, ferment in in a dark environment. So generally, okay, stuff that had been fermenting or curing for a while are rich in tyramine. They ask you a lot about what you teach a client with anemia, with iron deficiency anemia, which is the most common to eat. So the best iron is in the meats, poultry, fish, beef, organ meats, but not necessarily you need to eat animal food to obtain iron, because also the iron is present in vegetables, in the vegetable kingdom. Green leafy vegetables, um, ¿cómo se llama? Legumes, like for example the beans, okay? Frijoles, legumes, the dry fruits, the oatmeals. And there is a trick in iron diet. The 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 cereals and the breads in America are enriched with iron, with irons and vitamins. So if you check the label of those sandwich bread and those cereals, those breakfast cereals that we buy, you see that is added iron and vitamins, okay, which is beneficial. Is beneficial, and it prevents nutritional deficiencies in the population. And this is in Nclex. So was funny, no? Because you have which of the following four foods is recommended for a client with iron deficient anemia, and they mentions distractor, of course. Okay, distractors. Uh, in the end, the right answer was enriched breads and cereals. Okay. Notice that the orange juice does not have iron. If you enrich the orange juice with iron, will turn black and will taste horrible. The role of the orange juice or any other liquid that is rich in vitamin C and ascorbic acid, has the acidic pH, is to favor the absorption of the iron present in food or in tablets in iron supplementation. And remember that the calcium and the milk and dairy interferes, blocks the absorption of iron. And for that reason, people that consume too much milk can have iron deficiency. And it's the case of the milk anemia that happens in toddlers when they still have this sweet tooth for the lactose, and they still drinks too much milk. That's why they limit to 3 cups per day in the toddlers, okay, the intake of milk. Also, they are going to ask you a lot a high calcium diet. Just today, this morning, a student who presented the English commented me the question that had about nutrition is so common in English. Each question is are points that you add to your score and your possibility of passing. So she had okay high calcium diet. Of course, it's very easy to know that milk and dairy is very high rich is very rich in calcium, but it's too easy. So now trying to go to the less frequent sources of calcium of a person that, for example, doesn't like milk or has lactose intolerance. Yeah. And you need to know that the green leafy vegetables are very rich in calcium, especially the broccoli and the spinach. That the tofu, which is soy, is very rich in calcium. That the bony fishes, fishes that have bones in the spine, like salmon, sardines. Sardines, the one that appears more frequently. Tuna are very rich in calcium. The almonds and the tree nuts are very rich in calcium, very, very rich in calcium. And know, because it was in English, that the orange juice, which cannot be fortified with iron because it becomes disgusting, is yes, can be yes fortified with calcium. Don't confuse iron with calcium. Okay, it's different. Okay, and that has been in English. Remember that the vegetarians can be vegans that are absolute, are die-hard, nothing animal. So no eggs, no milk, no cheese, nothing animal. And the lacto-vegetarian or ovo-vegetarian. Ovo means eggs. So are big vegetarians that consume eggs. Or lacto-vegetarians are vegetarians that consume milk or cheese. And then in pregnancy, in all the pregnancy, you need to gain 25 to 35 pounds in total. I already mentioned that in the first half of the pregnancy, need to increase around 300 calories per day, but then at the end and during breastfeeding, 500 calories. Increase iron and protein needs, increase need of folate, and this is important. This can be tested. I didn't mention that in the maternity review because I include this nutrition in the class of nutrition to avoid repeating. Mercury is a contaminant of the oceans. It's a human contamination of the ocean with mercury. And now there are fishes that have too high levels of mercury in their meat. The bigger the fish, the higher the content of mercury. So the big fish eats the smaller fish, the medium fish, and the medium fish eats the small fish. So the big fish is absorbing mercury from the water, from the ocean, but is also incorporating the mercury of the medium fish that the big fish ate, and also the mercury that absorbs the small fish. So that's why the big fishes, the predators fishes, the one that eats other fishes, are too much mercury in their meat. And of all the big fishes that are predators, okay, the most commonly consumed is the tuna, the big tuna. Okay, they are huge fishes. Uh, but also swordfish, sailfish, fish, even shark in some parts shark is eaten. Okay, are bad for pregnant women because the mercury damages the brain of the babies. Cold cuts. Cold cuts. What is cold cuts? What you buy in the deli? Ham, mortadella, prosciutto, salami, all this stuff. Yes, and even the cheeses. The cold cuts can have a bacteria that produces listeriosis, the Listeria monocytogenes. This bacteria produce abortion. And raw vegetables can be contaminated with feces. Feces of animals, not only cats, but any animal, can contain the parasite toxoplasma that is also harmful for the fetus. Remember, in the first year of life, the infant need to eat more than any other moment of their life, because an infant should double the weight in 6 months and triple the weight in 12 months. Proportionally, you know what it means, proportional to the size of the fetus, the amount of calories per kilo of an infant in the first year of life is much more higher than an adolescent or any other person, because they need to double their weight and triple their weight, as I said. Honey can contain botulism, the spores of the botulism, the Clostridium botulinum. So the adults can kill, if there is a honey that we consume with botulism, we kill these bacteria with the acid of our stomachs. But babies don't produce acid in their stomach. So for that reason, if they consume honey, they can catch the bacteria and develop botulism, paralysis of the respiration. The first year of life, only formula or breast milk is allowed. Any animal milk can be given. After 1 year of life, yes, you can start giving, okay, the cow milk, whole cow milk, no reduced fat, whole cow milk. As I said, meanwhile, the baby is consuming only milk. They don't need water. They start drinking water when they start in consuming dry food, o sea, just solid solid food. The solid food is introduced around 6 months of age, one by one, not all at the same time. 1 week one, the next week other. There is not any order. Can be meat, vegetable, fruits, no order, but only one each week. Avoid, it is frequently tested, avoid giving juices, fruit juices to children, to infants and toddlers in bottle, bottle with nipple. If you are giving fruit juices, give them with cups, sippy cups, to prevent tooth decay. Remember the risk of choking, we already talked about this. If a child is an infant or toddler, presents a diarrhea, a viral diarrhea, a flu diarrhea, etc., the diet continues the same. There is no need of modifying the diet in diarrhea. In the past, and maybe some of us are still influenced by these concepts of the past, we gave a diet when somebody had diarrhea, mainly the bread diet, okay, banana, rice, apples, and toast. No, in evidence says continue the same diet, healthy, normal diet of always. So you can have some questions like this, which menu selection by a child with celiac disease indicates to the nurse that the child understand the dietary consideration. And then you have baked potatoes and baked potato chips and cola drink, peanut butter and banana sandwich, oatmeal, raisins, cookies, and milk, graham crackers, and fruit juice. So you need to know that graham crackers has wheat. The oatmeal, okay, has oat, and those have the sandwich has bread, so has it. So the potato has no gluten. The cola has no gluten. The option that you choose here in a question like this is A. Patient is on a low potassium diet that includes food as applesauce, green beans, cabbage, lettuce, grapes, and raspberry. Interesting because it's a good list of foods low in potassium. What type of patient you expect to be in a diet low in potassium? So I told you the more commons are renal disease and clients taking medication that elevate potassium. But look at this. They give you a question that didn't mention, in which didn't mention neither renal disease nor taking medication that elevates. They mentioned heart disease, osteoporosis, Addison disease, and recent gastric bypass. Based on the knowledge that you already have, I want to explore how is the knowledge. Which of these four conditions has high potassium?
Addison?
Addison disease. Very well, very well. And requires a diet then low in potassium. Make sense? Okay, so I can change the music to the way that we dance. Okay, this patient is in a lacto ovo vegetarian diet. What menu is appropriate for this client that is hospitalized and say, I want a lacto ovo vegetarian diet? So fish is not included in this diet. Milk, yes, and eggs, yes, but fish, no. Chicken is not included. Cheese, yes, and eggplant, yes. Eggs is included. Chocolate milk is included. So the answer is C, because oysters and turkey is not included in this diet. Now, are a stupid question, but you know what? Sometimes I use those questions in my test, and a lot of people face this question. Okay, just reading what means lacto, milk and dairy, ovo, eggs, vegetarian vegetables, then you find, okay, the right answer. Don't get confused. Sometimes people cannot chew and swallow. A person can be in coma for the rest of his or her life. If you ever work, as I work as an LPN in a nursing home or a skilled nursing home, you have some clients that are left permanently hospitalized in those nursing homes that are practically vegetables. Has a tube in the stomach to feed them, and you need to do everything: change diapers, bathe the clients, because the clients is like a vegetable. There are diseases that the patient is left alive and can live for years even, but is like a vegetable, is in a permanent coma. Or you can have people that have a stroke, Parkinson's disease, multiple sclerosis, neurological diseases that produce a distortion in the mechanism, in the coordination of the phenomenon of swallowing that we take for granted because you wouldn't have problems. But you need to understand that swallowing is like a miracle, because you have two holes and two tubes side by side, side by side. One tube, okay, is going to the lungs and should transport air. And the tube that is behind this tube is to transport liquid and food to the stomach. And they are side by side. And when you swallow or when you breathe, you know without thinking how to send the food and the liquid to the esophagus and the air to the trachea, So it's incredible. It requires a perfect automatic nervous system and musculature work. Sometimes this is impaired in people that have neurological diseases, like the one that I mentioned. I mean, stroke, uh, Parkinson's, multiple sclerosis, blah, 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 can have dysfunction, so dysphagia. Yes. Sometimes people have a problem in the esophagus, has, stenosis or obstruction in the esophagus, and then cannot swallow. So there are different conditions in which the client cannot swallow, cannot chew and swallow the food the way that you do and I do. In those cases, the nurse and the doctor, in working in coordination, collaboratively, can decide placing a tube in the stomach. So the tip of the tube is in the stomach, and through this tube, you can pass the food that the patient needs to stay alive. To deliver the food directly to the stomach, bypassing the swallowing, okay, you need to understand that the stomach and the intestine need to be okay, need to be functional. Okay, so once the food is in the stomach, can then be digested the same way that you digest the food in your normal GI. So the problem is here in the swallowing. Yes, the problem is here in the swallowing or in the esophagus, but must have normal stomach and normal intestine, because from there on is going to follow the normal natural process of digestion and absorption of the food. And it's basic to understand when we use enteral feeding. The enteral feeding is true that can be done through a nasogastric tube, but it's too risky. Why? When we place a nasogastric tube, first, the tube can be pulled out. If I pull out the tube, now the tip of the tube, instead of being in the stomach, could be, for example, in the esophagus, could be in the esophagus, because the tube can be accidentally pulled out. And then when we give the food, okay, the food can regurgitate and go to the other hole, and the patient can aspirate. The pressing of a nasogastric tube damages the mucosa of the nose and the mucosa of the throat. The pressing of a nasogastric tube occludes or closes the hole through which the mucus of the sinuses, the paranasal sinuses is the word, paranasal sinuses drain and can produce sinusitis. The pressing of this tube is going to favor that the bacteria and the secretions that are in the mouth and the throat go to the trachea, producing pneumonia. So the nasogastric tube cannot be left to feed a person for too long, So doctors preferred substituting the nasogastric tube with a percutaneous endoscopic gastrostomy. So a tube, a short tube that is introduced directly in the stomach through an incision, through a little hole in the abdominal wall, which is a very easy to do procedure. For doctors, it's very easy to do procedure. Is a minimum invasive with an endoscopy and with a little, local anesthesia incision, and the tube is introduced. This is much, much better because we can be sure that the tube is always in the stomach, cannot be pulled out, and there is less risk of messing here with the airway and all this stuff. That's why the majority of the clients that you're going to see have PEG tube. So when are you going to see nasogastric tube? In short periods of time, and mainly connected, the nasogastric tube connected to a machine that instead of introducing stuff is sucking, is pulling out the gastric content. So when a person has a gastric distension, ileus paralyticus, distended abdomen, pancreatitis, and doctors wants to take out this abnormal content that is building up in the stomach, when you see nasogastric tube is for suction more than for feeding, while you are going to see PEG tubes more for feeding. Okay, in this case, we are talking about nutrition, and we are going to be talking about feeding, not a nasogastric suction. And then, rarely, not frequently, doctors will prefer placing the tube directly in the small intestine, not in the stomach, but directly in the small intestine. In that case, it's called jejunostomy. Okay, don't confuse the jejunostomy with the ileostomy, which is other problems. Jejunostomy, yeah, very good. Is to feed the client. Okay, the most common is the PEG tube. So meanwhile, the patient cannot swallow, and meanwhile the intestine is working, any of those tubes can be used. For nutrition, for feeding the client. And the one that is in the stomach allowed to pass bolus. You know what is a bolus? You pass a volume at once, and only once. Yes, at once is the word. In only once doses that is repeated every 8 hours, every 4 hours, every 6 hours. This is the case with the stomach because it's the way that you eat. You eat 3-4 times per day, yes, and then you have a bolus, or you have a volume of food introduced in your bag, and the bag process the food. But when it can be done with a PEG tube. But when the food is introduced in the jejunum, you cannot do that. You cannot introduce in this small tube a bolus of food. Need to be a drop, continue feeding, a dripping, nutritional formula, a dripping continuously there. This is a big difference between the gastrostomy and the jejunostomy. And yes, need to be known for that purpose. Remember that any of those tubes need to be verified with X-ray. With X-ray, and this is the most important. When we cannot use a tube to put the food in the stomach or the intestine, when the intestine is damaged, you have a client with ileus paralyticus, you have a client with pancreatitis, you have a client with intestinal obstruction, you have a client with a short intestine, a client that the intestine is not functioning, then you cannot give food because the intestine is not working. So now the food is given directly in the circulation. It's called total parenteral nutrition. It's expensive, is very risky. The main risk is that if a bacteria contaminate this system, the clients can have a catastrophic fulminant infection called catheter-related sepsis or systemic inflammatory response. It requires a lot of care of the nurse because these solutions are very concentrated. Necessarily, the catheter need to be in the superior vena cava. And you know that the fact of inserting a central catheter has a lot of risk that we'll study in detail, like pneumothorax, etc., etc. But the main risk is the patient having an infection of this liquid that have a lot of nutrients and 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 a sepsis. The other risk that this liquid has a lot of glucose. And even if the client is not diabetic, the blood sugar, the glucose in the blood of this client tends to elevate. And you need to monitor this to prevent glucosuria and dehydration and giving insulin as ordered by a sliding scale by the doctor. You know that all the manipulation of this system is sterile and is done only by the RN, cannot be delegated to the LPN. Uh, this system should be changed every 24 hours to avoid contamination. And you cannot add in this system anything. The patient needs an antibiotic. You cannot add that here. You need to take another vein different to administer blood, antibiotic, whatever the other thing that the clients will need. This client need to be monitored. The glucose need to be monitored. The signs of infection should be monitored. The 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 daily weight, the fluid balance, the intake and output, daily need to measure the electrolytes, and all those parameters need to be monitored to substitute the oral intake with this only through the veins, okay, nutrition. By the way, those clients in TPNs rarely they have hunger. The high level of glucose, inhibit the hunger. They can have, craving, but no hunger. So let's see if you remember that this is a expensive and risky form of nutrition that is used when the intestine is non-functional. This is a Nclex style question, a reproduction of a Nclex style question. Look at this. I want you to think about this question. I'm not going to tell you the answer. The nurse understands that only one of the following four clients has justification of having total parenteral nutrition. Which client has a formal, absolute indication of a total parenteral nutrition of these four? You have a client that had a stroke and had dysphagia, and because the dysphagia has a history of aspiration pneumonia. So a problem of dysphagia, basically. You have a client that had a head trauma, very severe, is left in coma, in permanent coma, and has a bed sort in nutrition. As a client who suffers a psychiatric problem, anorexia nervosa, the BMI is very low and has severe chronic diarrhea, and has a client with cancer in the esophagus that obstructs the esophagus and is in radiotherapy. Of these 4 clients, which one do you think needs the nutrition directly in the vein?
D.
You say D as in David, no? This as in
Correct.
diamond. Okay.
Right.
Well, let me tell you something. Why don't you in this client, okay, that has obstruction here, why don't you put a PEG tube and feed the client through the stomach? Tell me why not?
Yeah,
Because
you can
this
do it.
this client has a problem in the esophagus, but the stomach and the intestine is okay. And then you make a much safer and cheaper decision with Diaz in David. Okay, so you need to justify the risk of placing the food directly in the vein. So need to be, this part cannot be functioning. So let's go back to the question.
C.
C.
Correct. C is the one that justify that. Because you have a patient with dysphagia, no problem, put a PEG tube. You are going to be hundreds of clients in your future that you are going to care that have a PEG tube. Why? Because they have dysphagia. Okay, and of course, also if the client is in coma, you can place a client in coma PEG tube. Okay, and even this can be a coma the rest of their life. It's going to be the rest of their life a PEG tube. And the cancer is the same. But what is the problem? This client is having a severe chronic diarrhea. What means that there is a disease in the intestine that if you start giving food to this client, the diarrhea is going to worsen and the client is going to not improve. Yes, and probably diarrhea is related with malabsorption. So in that case, because the intestine is not working, is justified, and because the client is severely with severe malnutrition, is justified administering the food directly in the vein. It is a, digamos, a reproduction, as a modification, as an interpretation of a question that one of the students had in his Nclex. So it is the concept that I try to convince you. This is a classical question in TPN. When clients are in TPN, their blood glucose is very high. And for that reason, their pancreas is producing a lot of insulin. So they have very high insulin. And even the nurse could inject extra insulin if the glucose is too high. So look at what can happen. A nurse is caring for a client who is receiving TPN, but the next bag of solution is not available for administration at that time. Which of the following is an appropriate action by the nurse? Does it, now you ran out of the TPN or the glucose. You
A.
don't have, okay. And then what you need to do, you need to prevent the reactive hypoglycemia that can happen in this patient. Correct.
A.
The answer is A. You need to hang independently. You don't need to be calling doctors to take this decision. It's a protocol. It's an standing order that meanwhile the next bag of TPN comes, you need to hang a dextrose 10% to be passing to this client to prevent the client developing hypoglycemia. Okay, hypoglycemia. Very briefly, you need to be knowledgeable about how nutrition and religion relates. You need to be knowledgeable about the main religions that we have in America. Okay, for example, Muslims, they don't eat pork in any form, including gelatin, jello. They don't drink alcohol, and they have 1 month every year that is variable, is a floating date in which they don't eat or drink since sunrise to sunset. Okay, so they wake up early before sunrise, they have breakfast, and then they don't eat anything or drink anything during the day until sunset, until the night when they have a sup. Of course, children and sick people that can be exonerated of those requirements. But you can have a question that you have a die-hard, a strict, okay, traditional Muslim that is hospitalized because a problem and has an oral medication at 9 a.m. When you come to give the medication, the client refuses the medication because it's in Ramadan. And then they ask you what is the intelligent solution of this medication ordered at 9 a.m. To document that the patient refuses the medication and that's it, or to change the dose of the medication to 9 p.m. when the clients can have that. So this is an example in which you can manipulate that. Uh, Orthodox Jewish have the kosher diet, which is very complex, extremely complex, but can be simplified by us because we don't need to be experts in that. Is no pork, no shellfish in any form, no shrimps, no lobster, no crabs, no any shellfish, no rabbit. They can just have fish, but not shellfish. And it's important, they don't mix at the same time beef with dairy. So for example, a cheeseburger is not acceptable. A hamburger without cheese, yes. Okay? And 2 hours later, 3 hours later, to have the cheese. They separate. They have cheese and they have beef, but separated. 3 hours separating this. For example, a lasagna which is has ground beef and Parmesan cheese and cottage cheese, no, ¿cuál es que usa? Sí, no. No sé cuál es el que se usa, okay? It is not acceptable, okay? So you have that in mind, that if you, a Jewish client is hospitalized, need to have a kosher diet. And the kosher diet must be supervised by the priest, by the rabbi, so is a very strict aspect if you have an Orthodox Jewish hospitalized. Jehovah Witnesses, anything that has blood, blood sausage, raw meat, etc. Buddhism and Hinduism is not frequent here, but are mainly vegetarian. Mormons, Mormons is an American religion. And the important about Mormons, no caffeine and no alcohol and no tobacco. Caffeine is contained in the Red Bull, in the all the stuff that you consume. You know that better than me. Of course, in tea and coffee. Seventh-day Adventists have a diet very similar to the Jewish, and they prefer to be ovo-lacto vegetarian. Okay, so it is something to know because can be tested. Okay, drugs related to appetite in nutrition, appetite stimulants. The one that I see more frequently mentioned in Nclex is megestrol. And you will graduating, you are graduated, you will be testing very soon, or will be, if you're not working very soon, we'll see how frequent doctors prescribe megestrol for as an appetite stimulant, especially for old people, very sick people that have anorexia, don't want to eat. Megestrol is a medication that stimulates appetite, but has progesterone-like activity. Progesterone, is one of the female's hormones. Um, it's a very weak progesteronal activity, but could, in some women, produce vaginal bleeding, and in some men, gynecomastia. Other medications for stimulation of the appetite, you have the oxandrolone. This is an androgen. This is like testosterone. This is control systems. This is control system because bodybuilders and athletes can abuse of this medication, and for that reason is controlled by the DEA, by the Drug Enhancement Agency. Um, um, the first generation, the old antihistaminic, especially the cyproheptadine, can be used as appetite stimulant, and the marijuana, the cannabinoids. There is a cannabinoid in the market forever. Okay, since I came to this country, okay, it is in the market. It's in the pharmacy. Is the marinol. is a cannabinoid. Dronabinol is the pharmacology name, is a derivative of the marijuana, which has been legal forever, comes in capsules, and is a controlled substance. When the doctor prescribes that, it's a controlled substance, and is given to the clients to stimulate the appetite. You know that the marijuana gives the munchies. So there is no need of smoking marijuana, which is harmful, or eating unknown doses of marijuana in ¿cómo se llama esto? In brownies, to have stimulation of appetite. In the pharmacy, forever, without needing of legalization or anything, is a legal marijuana called Marinol that is used frequently in the hospital, in the nursing home, for appetite stimulants. So be knowledgeable, because this way the politicians and the manipulators of the votes cannot manipulate you. Uh, in contrast, medication to inhibit the appetite are not frequently provided or prescribed because are very risky. The most used are the amphetamines. You know, amphetamines are addictive, are controlled substances, can produce cardiac arrhythmia, can produce problems. Phentermine, benzethamine, the methylphenidate, diethylpropion are anorexinogens, okay, that can produce hypertension, arrhythmias, insomnia, etc., and are addictive. So those were the topics about nutrition that I wanted to discuss with you today. It's a summary of the stuff of nutrition that can be in your Nclex. Any question?
Professor, I have a question.
Sure.
At the beginning of your presentation, you talk about the uterus and the evolution of the uterus. And I learned that it's a little change between the first hours and the first 12 hours. And
Yes, it's true. I never seen so detailed question in English.
Okay.
Yes, in the moment that the
Yes.
placenta is extracted, the uterus is so contracted, that should be at the level of the umbilicus.
Okay.
Then in upcoming 12 hours, relaxes a little, bleed a little, accumulate a little swelling, and then ascends 2 centimeters above the umbilicus. And
Yes.
from now on, every day is going to decrease 1 centimeter.
Yes.
I never seen, but Rebecca, never seen. You mean I've been spying the English all my life. I never seen so detailed question in English.
Okay. Okay,
Okay.
Professor, thank you.
But subinvolution and postpartum bleeding is frequently tested. But the classical, boggy uterus, retention of urine, deviation of the uterus, the classical, not the very tricky.
Professor,
Yes.
can you have a summary about heart? Like the heart?
I cannot understand anything.
Oh,
This
can
is
we have, like someday, can we have a summary about the heart?
about the what?
Heart. The heart.
Okay, I'm thinking when,
EKG.
because it's very long. I'm thinking
What
because
we
it's
have, what we need to know, because
very
it's very
long. Okay,
complex.
the heart review is very long, and we just left a very long OB. I want to cover a little fundamentals, because you are not very good. You are good in heart. It's too little what I can teach you about the heart. I know that it's complex, and you want a lot of, especially these rhythmias, to be reviewed. But I was
Yeah.
thinking that I like to cover a little more the fundamentals, because this is the area that I feel that you feel the most. That is fundamental type of test, etc. Because we don't cover that very well in the programs, and I want to advance a little in this. So I take that your petition in consideration. So as soon I feel that I cover a little more fundamentals, I'm going to test to review first heart. Okay, I promise that, Michelle. Okay.
Well, especially about those EKGs, because
Don't
last
worry,
time
don't
we
worry. It's
talked.
very simple. I can't give you a good orientation about EKGs and these arrhythmias for test purposes, not for education. This bootcamp is for oriented for the test. So don't worry, I will give you that. If you wait for me, but allow me a couple of more days to cover a little more generalities, fundamentals, because I'm so concerned there are so many questions, for example, about tests that use iodine, tests that use isotope radioactivity, tests that do X-ray, tests what are the requirements for an endoscopy, colonoscopy, etc. There's so many questions about those details. I want to cover that also first because I know that you know more cardiology than those topics. So I want to share with you my experience with Nclex question. Okay, about
Thank
this
you, Professor.
generality. Okay, so
Thank
after
you.
I finish that, I promise, Michelle, that I'm going to go over cardiovascular. I was thinking how I can program that. Okay, perfect.
Thank you. You will
Are you
have
good?
proceed too.
Okay, guys, on Monday the school will be closed and is not allowed to have activity. So see you on Thursday. Okay.
Okay, Professor, thank you.
Well, have a nice
Thank you,
weekend.
profe.
Bye bye.
Bye.